what you're going through. No other industry requires the level of study, education, and continuous learning as yours. Thank you for all you do. Not all heroes wear capes, some wear scrubs. So I can praise you for hours, and the reason is because all of you are contributing to helping solve one of the world's biggest problems. How do we make healthcare sustainable in the global south? I am a product of the Nigerian healthcare system. I was born in Lagos in St. Nicholas Hospital, which incidentally was founded by Nigeria's first Minister of Health, Chief Moses Majekodumi. For the Yorubas in the room, I'm sure you'd agree his name is very fitting. And I thank God for his vision. Interestingly, if you have not heard about him, I encourage you to read his autobiography. The title is My Lord, What a Morning. Now, my first exposure as an investor in the Nigerian healthcare industry was with Hygeia Group and Lagoon Hospitals, which I was involved with between 2009 and 2015. Lagoon was founded by Professor and Professor Mrs. Elebute, a husband and wife team, who dreamt of a healthcare system that created access and drove quality. Through their daughter, Mrs. Fololaoye, Lagoon has developed to become one of the leading healthcare businesses in the country and was the first to achieve JCI accreditation in sub-Saharan Africa. Prof and Prof Mrs. authored a book about their journey, and the title is A New Face of Private Healthcare, the Hygeia Nigeria Story. I would encourage everyone here to buy that book and study it. Incidentally, I would also recommend another book by Prof. Elebute. It's this book. It's the biography of a very famous Nigerian person who was called James Davies. James Davies was born in 1828, and he established the cocoa industry across West Africa. But he also was the founder of CMS School, which Professor Elebute went to. Thank you. I recommend this second book because when a great man of advanced age writes a book about another great man that has passed away a long time ago, you better make sure you get that book. Please, let's have a round of applause for Prof and Prof Mrs. Elebute. So, why the history lesson? As Isaac Newton said, if I've seen further than others, it is by standing on the shoulders of giants. And it is with that spirit of humility that I'd like to talk to you about what we've been building at Evercare. And I use the word we intentionally. I may have the task of speaking today, but I'm backed by an incredible team and a very diverse team. And I'm very deeply grateful to be associated with them. So a round of applause for Evercare and Irfan Khan, our group CEO. So, what have we been building at Evercare? Our vision at Evercare is to be the leading integrated healthcare network in emerging markets, transforming the quality of care and improving lives across Africa and South Asia. That vision relies on one word: collaboration. The action of working with others to produce something. Today, from an idea, Evercare now operates 450 beds across Nigeria, Pakistan, and Kenya through hospitals, medical centers, and diagnostics networks. Our journey was not easy. Over the last 5 years in Nigeria, we built and launched a new hospital during the pandemic, which according to the Financial Times is now ranked as the fastest growing healthcare business in Africa. In Pakistan, we launched a purpose-built tertiary facility, plugging a much-needed gap in the market and creating a magnet for clinical talent. And in Kenya, we invested heavily to transition a leading secondary care player into an emerging tertiary institution. In all the markets we are in, the focus was clear: deliver high quality and tackle systemic health issues whilst endeavoring to keep pricing accessible. Whilst we're proud about our impact to date, whether it be supporting governments throughout COVID-19 or continually delivering affordable, accessible care to underserved communities, there's still more to do, particularly around how we can truly serve lower income communities. So when we talk about sustainable healthcare, what we mean is creating systems that endure, adapt, and truly serve communities over the long term. For us, sustainability rests on three interconnected pillars. The first is patient safety. Safe care is non-negotiable. We strengthen local systems and leadership to create lasting impact. We embed robust processes and resilient infrastructure to enable consistent high-quality care. To top this, we seek external validation for our facilities by getting them accredited. The second pillar is what we call humanized operations. Healthcare is about people, whether they be patients, clinicians, families, or communities. Our goal is to operate in environments where staff feel valued and patients feel safe, heard, and cared for. We embed trust, dignity, and empathy into every interaction and seek to have cultural understanding and respect guide our partnerships and care delivery. Our method is to develop our people and treat our businesses like a training ground for future leaders. And I'm sure the people in the room from Evercare will agree with that sentiment. The third pillar, which as a financier is where we focus a lot, is financial sustainability. We take a collinear approach to finance, aligning financial decisions with our mission, not against it. Our principles are adequate profit with maximum impact, not the other way around. To date, we have reinvested all profits back into the businesses. We plan with a long-term vision and horizon, and we do not allow short-sighted decisions to compromise future resilience. Finally, responsible stewardship ensures that care remains affordable, hospitals stay healthy, and innovation thrives without sacrificing quality. Ultimately, our experience has shown one thing: sustainability is built by people who care. It's the commitment of our teams, the resilience of our communities, and the trust we foster that makes sustainable healthcare possible. So let's talk a little bit about the industry. I've had the privilege to invest across multiple sectors, and I have to say, healthcare has been the most difficult, because healthcare is not just an industry, it is an ecosystem. It's a set of complex, interdependent relationships. It starts with the clinician-patient bond. And if you see on this slide, we've been very deliberate to separate doctors and nurses, because one of the things that I find in this sector is the largest employee population in any hospital system is actually nurses. And without the nurses, you cannot deliver care. So please, a round of applause for the nurses in the room. Now, around that clinician-patient bond sits this complex web. You have shareholders like ourselves who need to create a return for the capital. You have the infrastructure that needs to be built, and not just built, but maintained and many times enhanced. You have the supply that comes into the sector, be they lab reagents, pharmaceutical supplies, and spare parts. You also have the communities and NGOs who are focused on particular diseases who want to partner with us. You have the academic institutions who both provide us staff and provide continuous learning. You have the technology, which is constantly evolving. You have the payer side, the health insurance, the savings plans. And then, of course, you have the government and the regulation. Now, as a healthcare business, historically, these were companies founded by doctors. And the focus was in that middle, the nurse-patient-doctor bond. For the industry that we imagine and where we need to go, we take it a step further and we look at it from everybody's perspective. And we try to create governance and structures that brings all these voices into the room. So one thing I would say to you is, if any link in this chain is weak, the whole system suffers. So I'd urge everyone in this room to think, what can you do to play a better part in ensuring that we create these strong links between all these parts of this complex ecosystem? The other thing that we've done, apart from just embedding an ecosystem thinking into our business, is to be very purposeful about innovation. And that basically means using technology as a catalyst. Technology is transforming healthcare everywhere. But in emerging markets, it has to be intentional. Innovation is not just about speed or scale. It's about who benefits and who's left behind. At Evercare, we're aiming to be at the forefront of technology adoption. And this has already been demonstrated in our theaters, in our consultation rooms, and behind the scenes in our administrative function. Lekki, for example, is a fully paperless hospital, which is very deliberate and was planned from inception. To make this technological adoption happen, we use what we call the ACES cycle to implement things, which is audit what's needed, build the system, measure the impact, and then scale what works. So in short, we focus on technology that enhances, not replaces the clinician's role. And the goal is simple: empower our people, not overwhelm them. The next area is investing in our people. This Evercare conference came from a need to gather our people together. I found that in healthcare, when you go to conferences, people tend to focus on their particular specialty or their particular disease or their particular role. And the idea was to bring everybody together. Let the people who are the nurses see what the surgical people are doing, see what the administrative people are doing, and really understand the breadth of this ecosystem. So we have established the Evercare Academy, and through that, we're training thousands of frontline clinicians and managers. More than half of our management roles are now held by women. We're driving knowledge sharing and collaboration through our Evercare Exchange. And you can see it in the data. Facilities led by strong teams deliver better outcomes. Our aim is to build capability in all our markets and create a bridge between the clinical and administrative functions. And it's important for me to also say a word about the administrative functions. When we talk about healthcare, we tend to focus a lot on the clinical side. If there's anything I've seen in these markets, is that the administrative side needs even more focus. We need to train more healthcare managers. We need to train more healthcare supply chain and finance teams. And we also need to train the support functions, security, catering, etc., that make our hospitals function. So, looking forward, these are the 5 things that we continue to focus on. 1, investing in infrastructure and innovation. 2, innovating responsibly for impact. 3, protecting our clinicians and patients. 4th, empowering our communities. And finally, collaborating across borders and sectors. Thank you so much for your time, and happy to take any questions.
Thank you for the wonderful session, Jide Olanrewaju. Very good to hear the strategies and goals that you're looking into ed sector, taking into ed sector. So we'd like to open the floor for the audience to ask questions. Also, I'd like to quickly acknowledge our virtual audiences, YouTube and every other streaming platform. We say good morning to you. So to bring in the moderator for the next 10 minutes, I would like to invite Dr. Aisha Mayan, the CEO and founder, Synapse Pakistan Neuroscience Institute. She will be moderating the question and answer.
Thank you so much. Good morning, everyone, and distinct pleasure to be here, and so lovely to be, talking to you and moderating the session. So, Jide, as I was listening to you, and also based on the conversation that we had on Sunday, I was reflecting a little bit. One of the questions that you'd asked was that what is the one thing you might want to change in the healthcare system? And at that time, I was very foggy and jet lagged. But it's an interesting question. And what I was realizing is, I read somewhere that the trust that people have in healthcare systems or in their doctors has fallen abysmally to sort of a small 20%. Like, people apparently seem to trust their hairdressers a lot more than their doctor. So what plans, this is fantastic, exciting, hopeful. What plans or what is your sort of sense of engaging with the community in terms of the work that you're all envisioning to do? And what would that look like potentially?
Thank you, Aisha. It's a great question. So I'll start by saying, let's take a big step back and ask ourselves why the trust fell in the first place. And my argument would be, it's the lack of transparency. When you get to the hospital, I would characterize the African patient as a passive patient. You arrive and you're just told things, told where to go, told what to take, and you're not really brought along. You don't understand how to benchmark one doctor versus the other. And usually, when bad things happen, that's the news that travels. So people will say, I heard someone died in that hospital. Oh, you can't trust them. Oh, I heard they overcharge. You can't trust them. And what I found is that as an industry, we don't spend enough time demystifying ourselves. And this is why, for example, something that Professor Kawar has been doing in Lahore that is exciting is this open ICU concept, where he allows the family to interact much more with the clinicians than you would normally allow. So my view would be, we need to start by asking ourselves, for every specialty here, do you have a booklet that actually explains what it is you do, that describes what the process is, the fears a patient will feel, what the side effects actually feel like? That you can say, the first time you come to me and you say, I want to see your bariatric surgeon, and I'm thinking of this, that you can say, here you go. This will demystify to you. You can ask any questions. That's how you start to build trust. And my view is trust is built individually, not at scale. So people trust that doctor, then trust the hospital.
It's word of mouth.
It's word of mouth.
Yeah.
And then I'll add one last thing. I also think that the other functions of the hospital could also benefit with that same transparency. Why don't you offer patients tours of your lab? Why don't you offer them tours of your catering? Why don't you show them how much work you put into thinking about nutrition when they're in the hospital? Why don't you talk to them about how you source the products that are part of their healing journey? I find the hospitals don't talk about those parts at all. You have CCTV and security guarding every single floor, protecting newborn babies. Nobody talks about that. So if you want to build trust, you need to expose people to the breadth of what you do.
That's a wonderful idea, and as you were talking, I'm probably thinking field trips for school children and college grads to the hospitals and
Exactly.
spaces. That would be great. And of course, now we have the Instagram channels and the TikToks, so those are also great spaces for you to sort of showcase the physicians and the nurses and the people, the humans of Evercare, right? I think that'd be great too. Well, we'll open it up for questions from our audience. Anyone has thoughts, reflections? Yeah.
Good morning, everyone. It's a special pleasure to be here and to hear this great man and this great Evercare team. And before I ask my question, I really want to implore the audience to give a round of applause to this wonderful man and this team. I do not mean to just blow anyone's trumpet, but what Evercare is doing here is the dream of better health for the Nigerian people. As most of you know, many people say that when Nigeria sneezes, Africa catches a cold. It is desperately important for Evercare to succeed in healthcare and ultimately for the Nigerian healthcare system to improve. All of that being said, by the way, my name is Dr. Olumide Oyefeso, and I'm a professional refugee. I live in Canada, but my heart beats in Nigeria. And we work to save lives in Nigeria, especially regarding infant mortality, which I got to speak about yesterday. And also, many people have asked me if I work with Evercare. And Dr. Khan, Dr. Shone Barry, I've been able to tell them that I'm a friend of Evercare. But my question is this. The things you have mentioned today are very, very important. I call it the triple M, MMM. Money meets meaning. Money meets meaning. There are many people who have money in this country but also don't know how to use it. I would like to encourage the team to continue what they're doing, and I want to find out about what are some of the unique platforms that we can engage on actively in order to continue to grow the vision that Evercare has and also explore new frontiers to improve this overall healthcare experience. Because there are many other things that can be explored in a sustainable way. That how can folks like me and others engage regarding those kind of some more topical issues? Thank you very much.
Thank you very much.
Thank you.
First, thank you for your kind comments. It's very much appreciated. Maybe for me, the first thing I would say, actually, Doctor, is I would encourage two things. The first is spend time with the students and the new graduates who are entering the industry. I think the mentoring and support to new people joining the industry is critical because they are the ones who are going to build this future that we're talking about. The second thing I would say is, as an industry, we need to think about how we can split the work better between ourselves. You know, there are probably 15 cath labs in Lagos. I don't think they're full. And when people think about building a hospital, everybody replicates the infrastructure of the next person. And I would like to see us starting to focus by saying, you focus on this specialty, we focus on that specialty, and we send patients to each other. Because I think our competition is not each other. Our competition is the status quo. And if we think of it that way, then we're more likely to build the sort of industry that you're speaking about. Maybe if you want to add anything.
That's wonderful. I mean, just the idea that we are shifting. Collaboration is the first thing that you talked about. And I do think that that is the difference. That's the thing that is discerning from how the West does it and how we would like to do it from the emerging markets differently. Because the problems are also all the same, but then, you know, it's not a zero-sum game. There's just enough for everyone to go around and a whole lot more. So, other questions? We'll probably have time for two more. There's one there, and then one there.
Good morning. My name is Temiloloa, and I'm a final year medical student at College of Medicine, University of Lagos. Thank you very much for this session. My question is, during your address, you mentioned that it's very important that we start to train the next generation of health managers, financiers, and all of that in the health space. And I wanted to ask, especially for people who are already interested in like health financing, health management, and the likes, right from medical school, how do we start to, you know, incorporate these skills, or are there avenues that these sort of people can pick up these skills, you know, such that when we're done, they're well sort of ready for the actual world and the markets? That's my question. Thank you very much.
Great, it's an excellent question. I think the first thing I would say is join Evercare. Because those skills that you're talking about is part of what we teach. So we don't just invest in the clinical side of your development. Our teams here can tell you we also invest a lot in the development of the management skills. The other way I would say you should approach it is think about what you can do outside healthcare. There was something in the panel discussion that we had, you know, on Sunday that Dan from ECAP said, which really struck me. He said healthcare is the only industry where he sees very, very little cognitive, diversity. And I saw it when we had the startup pitches on the Sunday. Everybody came and their team were just doctors. And the problem in the healthcare industry is it's so specialized. You study for so long that you only hang out with each other. I studied engineering. I didn't do anything in healthcare. And maybe that brings a different perspective when I engage with your industry. So my advice would be, how can you get exposure outside the industry to bring those practices into the industry? Because one of the worries I have for the sector is you're not growing fast enough to solve the problem. And if you see what's happened in banking, the reason the fintech players, I'm sure, who has an OPay account? Put up your hand if you have an OPay account. Okay, it's all in the young generation. Why do you have an OPay account? Because it always works. But the banks were there first. How come they didn't figure it out? Well, it's because they're not focused on really solving your problem. So my advice would be, really think about what are the big problems in healthcare and what are the other industries that could help solve those problems, because those are the skills we need to bring into the sector. I don't think administrative skills are going to come out of the healthcare sector. I think administrative skills will come from other sectors that we then bring into the healthcare sector. Hope that answers your question.
Well, having said that, Julia, I do believe that, so one of the gaps that we had in our medical education was that there was no teaching in financial literacy, there was no teaching in business management, there was just basics. So that you go out and all you know is disease. You don't know how to survive in, the big, bad world. So when you do set up your academy, I think those are definitely things to teach or build on or build those curricula. I know our time's up, but I just want to take one more question while we still have Jide. Rafiq, yes,
maybe two more.
Two more, all right, so two more.
Rafiq,
can you make that
afterwards,
quick? Yeah, if you could just make your question quick, and then Rafiq, if you could also ask your question, so then maybe you could answer both together.
All right. Thank you very much for this session. My name is Kayode.
Can you put the mic closer to you?
My name is Kayode Olabisi. I am the nursing manager for operating theater and cath lab at Evercare Lekki. Before I joined Evercare, at least I've spent exactly a decade in the public health sector. And one certain thing that I've come to realize is that with certainty, the redemption that the health service of our community needs will only come from private initiative, from the way we carry on in our public sector in those 2 decades. Now, there are 2 presentations so far in this conference that has witnessed that is talking about community service, and then making care affordable. As it is presently, the service of Evercare is concentrated here on the high end of the community. What's our plan to expand beyond the high end of the community? Because for us to service those people, we need to actually have a presence in those sides of the society. Are we working towards that? And are we conceptualizing something like insurance? Because recently, in the past 2-3 days, there's a discussion going on in the social media among some of my friends, like in a typical, person in our society now, you only need a major health challenge to descend you into poverty because of the cost and what it entails when you are sick or you have health challenge to take care of yourself. Are we, working around as Evercare Group to conceptualize something like a insurance that can help people for certainty whenever, health problem is unpredictable and it can come on anybody at any time, regardless of your financial status. If you have some, maybe insurance plan, of course, we have a lot of insurance around, but the reality of insurance coverage in our society. I won't talk much about that. Thank you
Thank
very
you, sir.
much. I will just stop at that.
Could we give the mic to Rafiq here so he can also ask his question? Right here.
I just have a brief introduction. I'm an anthropologist with a special interest in the medical field for historical reasons. My question has to do, and I want to say I really appreciate your lucidity. It was very clear wherever Evercare has a unique contribution and where it is going. However, I have a big concern about one large healthcare issue, which is population health, where the focus is more on prevention. And it's a different game from treating illnesses. We know that. Are you considering some partnership perhaps with another organization, another sort of entity that could complement your activities of healing with prevention?
Thank you, Rafiq.
Thank you. So I'll take, was it Kayode's question first, and then Rafiq's? So Kayode, I'm very grateful for your question, because if there's something that keeps me up at night, it's exactly what you described, which is how can you actually find a price point that is truly universal? I'll start by saying not every problem is the hospital's problem to solve. And I think, unfortunately, in our markets, we put a lot of pressure on hospitals to be everything. It's hard enough just saving lives. To then save lives at a certain price point is a double challenge. One of the approaches we took when coming to this market was we said, no matter what we do, we're going to price at or below the existing market. As you well know, we could have said with the infrastructure we can price much higher, but we realized that that would not fulfill our impact mission. But I do agree with you that we need the prices to come further down. But I'm not sure it's the prices that need to come further down. I think it's the contribution of healthy people paying for sick people that needs to increase. You see, in every other part of the world, you have a risk pool. 1,000 people will contribute, maybe one person uses the money. But what that means is the clinicians, the patients, the equipment can be purchased at the right level and paid for at the right level without compromising the quality of care. My concern is, before you go to those remote markets that you're talking about, you have to think about the ecosystem you need to build in that remote market. Do you have doctors that want to be based in Kwara? Do you have surgeons that want to be based in Kwara? And when you do have them there, do you have the supply chain in Kwara? So it's not an accident that you start in the place where you have the best ecosystem. But the long-term vision is definitely to reach those markets. But we have to do it in partnership and in collaboration with the insurance sector. It's not us that will develop the plans, it's the insurance sector that will develop the plans, and we will make those plans work for them financially. So my rebuttal to you would be, there were insurance players in the room yesterday. Did you ask them this question? Did you say, why is it that we don't have retail plans? We only have corporate plans. Similarly, why don't we have savings products or individual insurance products that people can buy? Even me, if I get sick with something like cancer, it will wipe me out financially. It doesn't matter how much I have. That disease is just expensive. And if you're using the same equipment, the same drugs, the same infrastructure as the global north, then the only thing that you can be cheaper is the clinician. And we don't want our clinicians to earn less than the global north, because then they'll all leave. So I don't think that pricing is something that you can talk about in isolation. I think we need to actually put pricing to the side and talk about risk pools. How do we create a healthcare savings culture? I can tell you that healthcare spend per capita in Nigeria is lower than mobile phone spend per capita in Nigeria. So if everybody gave the same amount that they spent on their mobile phone into a bank account, you would solve your healthcare financing issue in this country. So if I then move to Dr. Rafiq's question, yes, we do some work in that space. So we do run medical camps. In fact, in Kenya, we have a very long history of running medical camps, both screening and related. But again, this is an area where I think you need more partnerships. And this is why this conference was conceptualized. We would love to have collaborations from people who are passionate about this area. We're willing to make our resources available, our people available, to collaborate to work on that sort of mission. Thank you.
Sounds good. Thank you. Thank you so much, Ide, for this wonderful talk and insightful answers to the questions. And we'll end the session now.
Thank you.
Thank you, Dr. Aisha. Thank you, Jide. If I can just call on to stage now the Group CEO, the Chair, and the Co-Chair of the conference.
Is that private sector plays a majority role, a major role in the whole question of health system strengthening. So many of you, most of you are actually from the private sector. So one thing, just before I start, it's interesting, I used to do a lot of project work in Afghanistan. And very early on, when I used to be with the Aga Khan Health System, a lot of people would come and quiz me in terms of the impact that was being made in Afghanistan. But the question they kept on posing was, what happens when one of those, and this is way back, when the Taliban come to your hospital? So one thing which I think is very clear with all of us is that we are here to heal. When patients come into our hospitals, into our care units, we provide care to whoever is there. We are here to heal. So from that standpoint, I just wanted to sort of make a point that we are in the business of actually healing as best as we can. Now, question comes up in terms of what is health system strengthening and why is it important? So many of the young students here, you're going to be impacted in terms of this question. You may go into private sector, may go into public sector. But the big question is really going to be what exactly are we looking at health system strengthening? So one of the key things to bear in mind is that health system strengthening is fundamental to achieving what we call universal health coverage. Now, one thing in terms of declaration is more of an assertion. Universal health coverage is really an aspiration. I think for all of us who are in healthcare delivery, especially private sector, we understand that this is an aspiration very difficult to meet. To be able to provide access to individuals to ensure they receive quality care and services which essentially they can meet without financial hardship is a really tough process to go through. So bear in mind this is really an aspiration that essentially universal health coverage, we try to provide essential services to the population. Second thing is that universal health coverage basically has stalled a little bit. Because globally, when you look at the impact, the coverage that's been made, only half the countries have been able to provide access to essential services in terms of universal health care. Now, the gap it endangers both two things, social and economic stability. Now, yesterday we had a presenter who talked about economic stability. I think generally the idea many of us believe in is that healthcare is not just a social issue, but it's going to have a huge economic impact. Now, for those of you who were here yesterday, the gentleman talked about the question of economic growth, and we talked about Thailand, we talked about Vietnam, we talked about India, how they've made it into a growth sector. So just my own observation and a bit of a caution is that we first need to look after our populations in Nigeria, Kenya, before we start talking about exporting healthcare products, healthcare resources. Very difficult to do, it takes years and years. Generally, we want to make sure we can look after the populations we serve. Now, why is it important? Number one, like we said, a weak health system induces great risk to the social fabric of the community. Now, by the way, at some level, I don't want to make this thing theoretical. Unfortunately, if you don't understand the basic theory, and especially if there are so many students here, we are going to not be able to grapple with the fundamental issues of health system strengthening. So I'm going to go a bit into a detail of why it's important, and then we'll look at examples. So weak health systems really induce a great amount of risk for those of us who are in the delivery of healthcare, public or private. It degrades the community, it degrades economic risk. The other thing is growth markets, and we all know this. We have a double burden we bear. Now, Jide talked about this thing briefly. We are not only looking at issues of infectious disease, they are caught with this whole issue of non-communicable diseases. So it's well known, we have to deal with that. Strong, resilient systems need to deliver universal primary care. Now, the dilemma with all these things I'm talking to you about is they are really very, very important. One sentence cannot describe it. So why is it important? There is clear evidence that we need to be able to deliver most of the care, much of the care in terms of primary health care. We spend a lot of resources in curative care. So this is an issue both public and private healthcare have to work with, and we have to find a way around it. The other one is that health systems strengthening really helps the Sustainable Development Goals. So let's just move forward. What are some of the current challenges in health systems we face? Now, we've been here last 2 days, 3 days. Jide talked about this as well. The whole question of inequity of access is a major issue. We are going to have to solve it step by step, public sector, private sector. The one thing in terms of inequity of access, and this is something a lot of people in the healthcare delivery field believe, I believe in it as well, that we really need to take care of the vulnerable populations. When it comes to access to care and insurance programs, we really need to take care of the vulnerable populations, who are mostly the questions of women and children, marginalized people. So even us who are in the private sector, this is something really important to consider. The other one is the workforce challenge, and we know this. This is a major issue for all of us in terms of healthcare workforce. And that's why I was sort of cautioning that let's not worry about exporting our healthcare resources. Great source for income coming into the country, but we have to first look after the issues we have here. Now, the thing with current challenges, one of the key things is infrastructure technology. Jide talked about the level of technology as an enabler with private sector. This is a major issue for the public sector. There are systems which have very little in terms of electricity. And we have to be cognizant as the private sector, by the way. Because if you believe that we are really here in the country working with the public sector government, even though we cannot provide population health, we have to be cognizant that we're part of a community. A large part of the community has very little access to electricity. There are major gaps in terms of technology as well. A lot of the public health systems still rely on paper records. So we are now working, if we believe we are going to be working in a country, in a population where we want to enhance the social fabric of the country, we are working with public resources which are fundamentally inadequate. Funding for the systems themselves, very, very difficult in terms of public sector funding. So again, I won't spend too much time on this, but just to make you aware that in terms of the amount of money we spend, take Nigeria, take Kenya, take Lahore, right? The level of funding for publicly funded resources is very small. Now, quick look at total spending per person. And why is it important? Because the amount of money generally that we spend in healthcare has a lot to do with the level of the population in terms of healthcare. And the more money we spend generally, not frivolously, but the more money that is spent per capita, the better the community is in terms of health delivery, health outcomes. You can see here the light greens, Nigeria, Kenya, Lahore, Pakistan, very little in terms of spending. So this is just for your information that we're working in this environment. If you look at the public spending, by the way, these are indices globally used by every major institution that looks at it, whether it's the World Bank, IFC, whether it's any public institution, the public spend as a percentage of GDP. Now, I think, and I don't have much time, but I would have loved to quiz you in terms of what the public spending as a share of GDP is in Nigeria, but it's right here. It's very low. So part of what we need to do collectively, public sector, private sector, is find a way to encourage the public spending to increase, because having this level of spend, and you can see that, it's extremely low. As a percentage of GDP, between 0 and 2% is extremely low. Kenya is a bit higher. Nigeria is a bit higher, between 2 and 4%. The Abuja Declaration, remember I mentioned to you that universal health coverage is an aspiration. Abuja Declaration was what, 15%. It's a long ways to go, right? Even if you can get incrementally over the years, increase the spending per capita, this is really, really important. And sometimes when I present these indicators, I'm saying to myself, is it important in a conference to really understand? Absolutely. Because from a background context, look at the amount of spending of out of pocket. Generally, in the work we do in terms of financing and funding, we want to try and minimize the amount of funding that comes out of pocket. Now, for all those who are wealthy, affluent, spending 20, 30, 40, 50% out of pocket is not an issue. We are part of a community where, and Jide mentioned this, right? Even if you get one incidence of cancer, doesn't matter which it is, but it may wipe out the family. Can you imagine people, the vulnerable populations, the women, the children, those who are unable to afford care, the amount of money they spend out of pocket? For them to spend 70% is basically their entire income, right? So just keep this in mind that we're part of a community where we have to figure out how do we actually reduce the share of spending out of pocket. Really, really important. Now, I'll just go through this thing very quickly because I want to really break into sort of a Q&A. So what are the components of health system strengthening, and why is it important? We are in the delivery of care. We need to understand essentially where the issues are in terms of what is health system strengthening. So one is policy and governance. Now, policy, like I said, easy to say that the foundation of the entire health system strengthening is strong, effective governance and sound policies. Now, again, if there are public sector figures here, I do say it with great sensitivity, that public sector governance and policies are really, really important. Take a simple example. Again, I won't go through the whole thing. The Kenyan government some time ago came out with a national health insurance plan, which was made to be not mandatory. They decided that this was something that's needed, social insurance. And by the way, when every country is thinking through the whole question of insurance or funding, it's a very fundamental question. Do we tax? Do we put that through a process where everybody pays through the taxation? Well, Kenya, Ghana, Nigeria as well, there's no way it's going to work because not everybody is in a formal sector, right? So people generally have a lot of informal. So that's not going to work. So Kenya, like a lot of the governments like Nigeria as well, decided to go with a national insurance plan, premium-based, which makes sense because then you start to have people pay a premium. Now, what's the fundamental mistake you think that a government makes when they actually say that, we'll put a national health plan, premium-based, but we're not going to make it mandatory? Okay, fundamental mistake. And again, I say this with all due respect to my colleagues. And I do this a lot, by the way, in conferences in Kenya as well. And I have to be very careful. There are ministers sitting there, and there are, adjuncts of the policy people sitting there. And I have to be very upfront and say it with all due respect that we cannot be implementing policies which have an impact on the country, which are not designed properly. So when you put up a national health insurance, Nigeria mandated it. The only way it works with a public health insurance plan, and Jide mentioned this earlier, the whole question of pooling. It's just part of the way things work. So in Kenya, what happened, NHIF essentially went bankrupt, and then they had to change it to a different program. So anyway, bottom line is policy governance extremely, extremely important. Now in private sector, and I'll be coming to this a bit later, but I'll say it right now, how do we collaborate with the public sector, stakeholder engagement? What exactly is it? It's a fundamental component of health system strengthening. So not only is stakeholder engagement important with the public sector, because they did this thing very effectively. Example is in Ghana, they wanted to develop a program to forge consensus on expansion and remuneration. So anyway, what they did was very successful. Through stakeholder engagement, they engaged the entire process in a very fundamental way. Improved a lot of the public sector salaries, unified scale, improved retention significantly. So point here is the stakeholder engagement is extremely important in health system strengthening. Now, private sector, where does it work? We have to really look at health system strengthening stakeholder engagement in several areas. One is private sector has to engage with the public sector. There are many, many programs, designs that the public sector is making today, right now, where private sector, all of us who are here in private sector, we have to engage with the public sector. We can do it through our associations, we can do it through other avenues, but engagement is really, really crucially important. Last conversation with Jide, question came up, how do we enhance collaboration? So stakeholder engagement also means that how do we collaborate between the public and private sector to expand the range of access we have in our private sector. So that is really, really crucially important as well. And this issue of brain drain and how many staff we have, and just look at this graph. I don't want to spend too much time on it. The number of resources we have, and we generally bundle these things up because we look at how many doctors, midwives, pharmacists do we have as a percentage of population? It's a very key measure used by all the World Health Organization and IHF and all those guys. Look at the numbers we have here in Africa. Pretty dismal. We have a long ways to go. So one of the key issues that we're looking at in terms of components of health system strengthening is workforce development. And again, I'll go through this thing very quickly. Major issue. Whether we're in public sector, private sector, I gave you the example of Ghana. And what they did was they were very effective through governance and through policy and stakeholder engagement. They were able to double their workforce engagement or workforce volumes, all skill levels. Now, I have to also tell you about Rwanda, because I was in Rwanda a month ago, and it's just staggering. This is, again, public policy. Talk about bold actions. Rwanda, the government has decided to go with this 4x4 policy. Very ambitious. They want to be able to have quadruple all their, and again, across dentists, doctors, nurses, pharmacists, the whole thing. They want to build a 4x4. In 4 years, they want to quadruple it. Now, many of you may think that it's too ambitious, not doable, but this is one of those very bold actions that they expect to actually do that. The other component we talked about, really important, is integration of care. Every health system strengthening really depends on the integration of care. Now, a question came up earlier as well, right? Integration in terms of how do we actually bring all the care into a process that's integrated. Now, private sector does this thing in a fairly similar way, which is to have a hub and spoke model. They work really well. So you integrate all the care, you integrate the tertiary care, integrate the secondary care with primary care, which is out in the community. So really important. Ethiopia, as an example, again, set up a 3-tier system. And it's a public system, but it works really well. Health posts refer to secondary hospitals, refer to tertiary hospitals. And then you have to actually have a mechanism for referral, which works really well. Now, for some of us who work in Pakistan and Kenya, in private sector, generally people will go to see the specialist. There's nothing one can do about it. It's just the way generally patients work, right? They want to go and see the specialist, not the most effective way. So generally, if you can triage them through general practice and then move them into specialty care is the way to go. Now, there's a really great example here in Nigeria in terms of integration of care, private sector. The question was when patients need care, oncology, they go to different places for the diagnosis. Sometimes they have to go different places for the radiation therapy. So there's one example here. The CEO spoke about it 2 days ago, integrated oncologist service. So that's an example of integration that works extremely well. The other one, health system strengthening, digital data systems, crucially important. There is no way in today's healthcare system that we're going to be able to do anything meaningful if you don't have the data systems and the decision-making systems. So if you look at public sector as an example, now, by the way, some of you will, and I think rightly so, challenge me on this one that you really can't talk about UAE. I mean, UAE is not an emerging market. I concede. The example, though, is very good. They've integrated the entire system in Dubai, completely, in all GCC, completely integrated system. Private sector examples, digital health innovations rampant. I'll show you an example that worked really well. This was in Pakistan, an app that, and this was very successful, by the way, 3 provinces used it. It does registration, it looks after maternal child health, it tracks vaccination, immunization, extremely successful. If you look at a population health issue, it was actually solved by a not-for-profit institution in Pakistan. So there's a lot of innovation already happening in that domain. Financing, Jide talked about it. My time's up, so I'm going to move through it very quickly. Financing is a big issue, and so I won't spend too much time on it, but just to make a note that when we're looking at funding and financing, in private sector, it's mostly through corporate or private insurance corporates paying for it. And then public-private partnerships, very quickly, very important. These are examples of how public-private partnerships actually work. They're extremely well designed, by the way. You have to be very knowledgeable and technically competent to do a public-private partnership, but they're very, very important in terms of being able to provide access for care with public sector. And they work really well if they're designed well. Public-private partnerships, we talked about it, extremely important. If you're looking at health system strengthening, this is one of the most important ways to develop the health system is public and private partnerships. As I mentioned, there are two examples in Nigeria that you know of. So one is the one that, in fact, the gentleman was here yesterday with the Africa, with the Lake Abuja project. So I won't go into the detail. Lastly, just a quick note here. Kigali has set up one of the foremost training programs. This is as good as you get anywhere. You get surgeons training, wet labs, dry labs, all Africa-based faculty, just amazing stuff. You would think this is actually going to be somewhere in North America. It's right here in Africa. So final thoughts before we go into Q&A. I'd really like to get into more of a Q&A. So final recommendations is in terms of strengthening health systems. It's very straightforward. We need to reorient our health systems and priorities. This conference is a great example of how we engage and collaborate to do that. Strengthen primary healthcare, really, really important. Increase investment in healthcare and build the economic engine. Now, I have to reinforce this a little bit. I work a lot in North America as well. I work a lot in Africa. We have a tremendous opportunity to generally develop healthcare through innovation, through research, through development, develop healthcare as truly an economic engine. Very, very doable. But there are many areas where we really are not focused, especially around research and commercialization. So huge impact. We have to reform our health financing system, strengthen governance. By the way, strengthen governance, private sector, public sector. Now, Jide gave an excellent example of what private sector governance looks like. You got a pretty clear idea. Well-governed system. Public systems, we have to engage with the public systems just to make sure that some of the systems and methods of governance are really going to work well. Last one, strengthen collaboration with domestic international partners. Question has come up quite often, collaboration. I think the one area where in Africa we can do a lot more in terms of collaboration is working with international partners, because many international partners generally don't have much of an understanding in terms of what emerging markets Africa is doing. And I'm fully convinced that there's a lot of things we're doing. In fact, the conference was set up. If you look at the logo and the conference concept, that emerging markets are taking the lead. Right? They're not waiting for any other north-south collaboration. They're actually taking the lead. So this is really, really important. And then, of course, increasing investment in health technologies as an enabler, crucially important. Today, I don't think there's any way we'll have a durable, resilient system. Easy to talk about resilience, but this is really, really key. To have a resilient health system that's sustainable, we need enabling technologies. So I'll stop there. And please, if we can have a Q&A, I'd love to just have questions and have a conversation with you. Thank you.
Thank you, Professor Salim. Can you hear me? Yes. So I'm Dr. Kate Talenko, and thank you so much, Professor Salim. I'm the CEO of Corvus Health. And thank you so much for your presentation. You gave us a lot of food for thought. And I remember earlier in the conference, someone said that in emerging markets, we don't have the resources, but we have the innovation. And we have seen Evercare already fostering innovation internally in training and supporting its staff, and externally in the pitches that we had on Sunday of the entrepreneurs. What are some other ways that Evercare can foster innovation within its own system, in the private sector ecosystems in its countries, and also the general wider public health ecosystems in its countries?
I think this whole question of scaling innovation is crucially important. This conference is a very good example of private sector taking the lead to bring together all the stakeholders. Now, I'm particularly grateful that a lot of the students are here because as an educator, the impact that this kind of a conference has with the students who are here is very significant. The other one is the level of collaboration that takes place It doesn't start with the conference by itself, but it starts with people getting together and then talking about projects where you can start to collaborate on projects. So for example, Jide talked about this question of, there are lots of technologies, processes which we duplicate. One of the areas which in private sector would be of great value would be for the private sector to find ways to collaborate in such a way that more expanded tertiary services are developed in a way where not everybody needs to do it. So one of those, in fact, I was talking to the CEO of Evercare, there's this whole question of organ transplantation. If you look at Nigeria, for example, the degree to which some tertiary specialties are not here is really amazing, because why do people have to go all the way to Turkey or go to Singapore or wherever to get the level of care? We have the capacity here in country. So I think those are examples of collaborations that can take place.
Great, thank you so much. And we know that Silicon Valley has the expression, move fast and break things. That's not exactly something you can do in healthcare because we're working with people's lives. So what are some ways that Evercare and other health systems in innovation can make sure that patients are kept safe and that standards are maintained while we innovate, for scale, for cost effectiveness, and for resiliency?
So, and you're right, healthcare is not one of those where, because we're dealing with human lives, we're dealing with people's needs, immediate needs, because their issues and their patient experience is crucially important for them. So healthcare is not one of those where you can move and break things in terms of innovation. So we move very diligently, very cautiously and safely for the right reasons. Now, having said that, there are areas where we really can start to make fairly significant moves to enhance the quality of care, the patient experience. And one of those, by the way, I'm just being open with you as colleagues here. I think generally in Africa, we're moving a bit cautiously and slowly around this question of integration of AI and agents, and it's like we're waiting to see how this whole thing unfolds. Now, I have seen in North America and Europe where health systems are taking it on very directly, looking at how this is going to move, understanding it. They've got people in place to figure out exactly what the impact may be. So I think if there's one area where we don't need to break, but really need to get quickly to understand how it works, and maybe bring on processes that are there right now, and not wait for somebody else to figure it out. So I think it's one of those areas in terms of digital platforms that we really need to take a bit of a lead. Can be done jointly with groups in Nigeria, but you need to get forward and understand it and maybe use some of the processes early because they work quite effectively.
Great, thank you so much. And I don't want to hog Professor Salim, so I'll open it up for questions from the attendees. Any questions? Yes. And any other people want to raise their hands? Yes.
Hi. That was a great presentation. Thank you so much, Salim. So quick question. I was just thinking about Evercare, right? So from a health system strengthening perspective, most of us in healthcare, we're not trained in a health system-driven approach. And I think it kind of relates to the earlier point about doctors and nurses not being trained in financial literacy. So I was just wondering, would you suggest, would you recommend that a place like ours, we should, everything that we do, should it have a component of public-private partnership perhaps, or how do we build up on our projects or programs so that there is a health system strengthening approach? Would it look like a department or some division within the hospital or across the platform that guides us accordingly as well towards a health systems-driven approach?
So that's an important question. So, I'm just going to give you a personal bias. I run hospitals, and I'm also an educator. So I have a bias against training and teaching clinicians around the whole issue of finance and all that. I think that's a fundamental mistake, because clinicians really need to do what they do extremely well. All they need to understand essentially is the dynamics of finance, but they don't need to become a financial person, right? So you need to figure out where your niche is. Now, health system generally, for those of us who trained in health systems, understand that the system, and again, Jide mentioned it's a very complex system. Unless you take it on as a specific role as a chief executive or as part of an engineering team in a hospital, that's your job. So don't encumber the other folks you need to make sure they're really very good in what they do. So part of the thing in terms of strengthening your own health system is the things that Evercare is doing right now. Talking about issues of empathy, leadership training, and essentially making sure every person does what they do extremely well. And then the whole question of empathy and trust is crucially important. Because the fundamental notion which is being pursued right now is let everybody do what they're doing in teams. They know exactly what's happening. So my response to you, Asad, would be, in terms of health system, it's levels really. Let people engage in things. You build the system around it. You should make sure the enabling environment is there. So clinicians and nurses and doctors get to work in a culture, in a system, and they can use it, but they don't need to become system engineers or financial people. You design the system around it. It's just a personal bias I have. Now, I think this conference has given a lot of us here a clear idea in terms of the way, the Evercare way. And I think there are clear parallels that other institutions can use from that. Because you've got a whole system. You've strengthened it through training. You've strengthened it through collaboration between Lahore and Nigeria. These are real innovations that work. So I would respond in that way.
Any other hands? Yes.
Hello, I'm Dr. Aisha. I'm a neurologist from Lahore. I had a talk yesterday on stroke management, which was pretty relevant, but the real thing I would like to talk, I would like to use this platform to know what we are doing here in Nigeria, because the stroke burden is about every 7 people out of 1,000 are suffering stroke, and given the amount of care or the non-availability of general health provision leads to the mortality of up to 40%. So the acute management in stroke is very, very expensive. As the students here in Nigerians, they asked me yesterday as well. I would want to know what financial models is being employed, and if it is not being employed in acute stroke management protocols or pathways, what do you see can be done, because this is a huge health burden all over Africa, where hypertension is extremely, extremely high. I remember our nephrologist from
so to clarify the question, you mentioned the specific case example of stroke and how it's so expensive, and how can we drive down costs, of very complex disease care to be able to scale it, whether it's stroke or something.
Thank you. Yeah, I was having a bit of difficulty. So again, a really important question in terms of specific modalities which are important to the community and have a huge impact. So part of the challenge is going to be in the private sector is to find ways to make care, even in terms of stroke management and hypertension, which are really important, because in terms of the amount of disease they cause, the amount of condition in terms of disability they cause is huge. So a couple of responses on that. So one is in terms of affordability. What many hospitals do right now is that if there are patients who have, they don't have access to the level of care or funding to deal with specific modalities, especially around the questions you raised, they provide access to support. Now, Evercare, I'm not sure exactly what the policy is, but I'm pretty certain that if patients came and they needed access with reduction in terms of fees and all that, every hospital I know caters to patients who really have no ability to pay. The other one is hypertension. Those areas are really all outpatient-based programs. Many institutions, like I'm sure Evercare does it, but most hospitals take care to make sure that they address those issues on an outpatient basis, and they have medical camps to do the diagnosis and all that. So apart from that, in terms of access to those conditions, I think the other thing, of course, and again, Rafiq asked the question of population health. And these are sort of the innovations that I think hospitals and public sector can work together to make sure there's a referral process. Just in the event that there's a clinic which is publicly funded, patients cannot access it, you help them the best you can. You bring the fees down. But there are ways to collaborate with the public sector as well, so a proper referral can be made.
Thank you so much. Before we wind up, I want to give a quick answer to that. So I think that Evercare in its outpatient work and public health work can focus on primary prevention, preventing people from getting hypertension or heart disease or diabetes in the first place. Secondary prevention, screening to make sure people know they have hypertension, know they have diabetes, and that get the proper treatment for that or weight loss for that. And then thirdly, you have to drive down the cost of the services. Like, do you know how much it costs you internally to take care of a single stroke patient? Have you calculated the inputs? The majority of the cost of the inputs is going to be health worker labor, and then after that it's going to be your drugs, equipment, overhead of the hospital itself. And then you have to redesign the team and the pathways to drive down those costs. But thank you so much. We appreciate it. Our time is up, and we appreciate your questions.
Thank you so much, Professor Sally, and thank you for moderating, Dr. Kate. So I would like to have on stage the board chairman, Avenue Kenya, to please present the plaque of appreciation. Dr. Lawrence, please. So quickly to the next session. Okay, photograph with the moderator. Thank you. The next session is talking about addressing burnout in healthcare, and I would like to bring on stage Dr. Aisha for our session.
So hello everyone, a bit of shift of gears here. We'll talk about burnout in healthcare professionals in low middle income countries, recognizing the crisis and building sustainable solutions. So before I go on, I have two people to thank for me being here. So first of all, Irfan. Thank you so much for inviting me, for doing all that you do. So just a quick piece of history. So I've known Irfan since 2015. So it's been about 10 years. And on and off, I've seen him take leaps of faith. I've seen him take risks. I've seen him grow and get into spaces of greater and higher impact. But three things really have remained very much common in how he's practiced. One of them is just sheer grit and perseverance. And I say these things because these are absolutely applicable to when we talk about burnout. So perseverance and grit through all of the difficulties that he's gone through, and I know that he's gone through quite a few of them. The other piece that has been important for him from a very long time ago has been creating systems that are centered in empathy and compassion. And we've now talking a lot about it post-COVID, but even pre-COVID, that's something that I think he intuitively got and really worked hard in a time when healthcare systems were really primarily focused on profits. But of course, profits are important, business is important, but I think it's always been wonderful to have him think about the human-centeredness of it all. And the third piece that I think has been fantastic to watch through these years is just this nurturance of the team and bringing the team together towards a shared goal, a shared vision. So if your vision is good, if the purpose is there, then the teams do come together and do want to work towards it. So thank you, Irfan, for all the work. I've been hearing words like charismatic and your beloved group CEO, so round of applause to him. This picture is from 2017 in his parents' home in Nairobi. We have Parveen here and Irfan and his parents. Really wonderful time when he had called us to do some work in Mombasa. The other person that I want to thank, do you all recognize this gentleman here? Yes. So Dr. Asad Mia, we have a bit of history, 30-year history between us. But I say thank you because I received a very gracious invitation from Dr. Ayo a few months ago to come and join you all here. And I am in between two international travels, and just this Saturday we had like this huge youth mental health concert that we do, that we set up in Pakistan annually. So I wasn't quite sure that I'd be able to make it, but Asad kept nudging me and urging me that you'll meet just absolutely wonderful folks. Please come. And it's been an absolute delight being here. I think just watching the Evercare family, just seeing what you've already achieved, and also just a lot of hope around where this is going. So thank you, Asad, for nudging me. Here we are in Rio last year, where I had gone for a lot of work and he had gone just for fun. So this is from last year. All right, so a bit about me. I have gone through, I think, different lives every 5 or 10 years. I've shifted from being a psychiatrist, child psychiatrist, a lot of leadership work, a lot of gender work, and most of my life has been spent in academia, but I think around 2021 when COVID happened and a lot of stuff happened in academia where I sort of felt that my work now had to shift towards more social enterprise. I took a leap of faith and started an institute which we call Synapse. The idea is around just reimagining connections. And we've been talking about collaborations, and we've talking about how to create communities of practice. So that's what we do. We do everything to do with mental health in Pakistan, from clinical service to policy to advocacy to consultancy. And our values, expansion of choice, which is a very important one for me, and again, very connected to burnout. If you at any point in time feel that you have the choice to do more, to do what you want to do, it's a very feminist value, but I think that that's something that if you can integrate within your space to understand that there's space for you to do more, and Evercare has really shown that each of you in your own capacity can be much more than what you think you are doing. It really works well for the building of emotional intelligence and resilience. And of course, we've been talking about excellence, justice, creativity, courage. So those just some things that are close and dear to me. All right, so we'll talk about burnout, but I do want to say that having just observed what all is happening at Evercare, I do feel that you're already a fantastic case study on having created a system of resilience. So what I will be doing or talking about is probably just reminder for you all, maybe even obsolete because you're already way ahead in this journey. So that's absolute wonderful. So congratulations to all of you on that. So what is burnout? So defined by WHO, it's a syndrome from chronic workplace stress, which is not successfully managed. And really, I think it's just become a lot more of a thing since COVID. It was happening before. It wasn't that that there was no burnout before, but it really came to light around that time. There are 3 key dimensions: emotional exhaustion. A lot of people talk about empathy fatigue or compassion fatigue. Depersonalization, like you feel that you're there, you're showing up to work, but your full self is not there. Your complete self is not there. It's almost like an automaton. You're coming, you're doing the work, and you're leaving. And then, of course, reduced personal accomplishment. Like, you're doing the stuff, but you're not feeling good about what you're doing. It is an occupational hazard, so one has to understand that it's not personal. It's not that you are not doing something right. The occupation and the way the systems work, set up, it's the occupational sort of, not necessarily fault, but that's where the light needs to go rather than looking within. Why do we need to focus on the lower middle income countries? Burnout is not just a phenomenon for Islamic countries. The global north also, people suffer from it. Again, during COVID, there was a lot of moral injury that happened, which led to a lot of burnout. But what happens in lower middle income countries is that compared to the global north, where about 40 to 50% of health workforce reports burnout, over here it's 70%. Reason, of course, is, and we've talked a lot about it, there's severe workforce shortage. WHO estimates about 10 million people deficit, mostly in the Islamic countries. So we are 10 million people short of providing the kind of health care that we need to provide. We have limited resources. We know that the demand is high. The moral distress is significant. And of course, there was a post-COVID surge in emotional strain, which accelerated burnout there was fear, there was a lot of loss, and that loss continues. I still have people talking about the losses that they endured, personal losses, patient losses, family losses around COVID time, and overwork, which has actually led to a lot of attrition. We talked a little bit about how healthcare workers are actually leaving the workforce in big numbers. And it has become, again, a big crisis that globally people are looking at. We also have limited local data. So whatever we talk about, whether we talk about mental health or child mental health, the work that I do, or we talk about hypertension, or we talk about diabetes, most of the data that we think about is coming from the West. It's not necessarily applicable to us at all. So not everything fits, and that is why we have underreporting and sometimes overreporting. And then, of course, there are cultural barriers to admitting sort of the attrition that's happening in the healthcare workforce. So burnout here is magnified by inequity. The expectations are the same from all of us, but the tools that we have available for us are much fewer. I talked about increase in burnout, not necessarily burnout post-COVID, but definitely reporting. So a study found that from 2019 to 2020, there was a 36.2 increase in the papers that were written about burnout. Before that, it was about 17 to 20%. And then, of course, the top years for burnout research were 2020 and 2022, with about 106,000 publications respectively. That's huge. Before that, there used to be maybe 10,000, 20,000 a year. Then we are talking about 106,000 publications on burnout, which is fantastic because now we're getting it that this is important. What is the cost of burnout? Why is it important? It's not just that one healthcare professional that is having a hard time. Anyone who's burnt out will be providing a decreased quality and safety of care, right? So while we're talking about patient safety, patient quality, we've been talking about these things all day yesterday. It's important to understand that burnout will cause that. There's increased absenteeism and turnover. Migration, we've been talking about brain drain quite a bit. I think Irfan mentioned yesterday that he doesn't mind people jumping ship from Evercare to other hospitals in Kenya, Nigeria, and Pakistan, but he doesn't want them to leave the country. And that's what we are really struggling with. I started the first child psychiatry or child and adolescent psychiatry training program in Pakistan in 2015 or 16, and we've trained about 10 child psychiatrists since then, and 6 have already left the country. It takes 2 years to train a child psychiatrist. So these are real problems that we need to look at and work with. And of course, we talked about trust. Why is there a decreased trust in doctors and in the health systems, down at an abysmal 20%? And that's also the cost of burnout. So it's a health system failure. Drivers of burnout: chronic understaffing, excessive workloads, low pay, job insecurities, inadequate supervision and leadership support. There's stigma around seeking help. So many, I think, hospitals and healthcare systems have set up crisis lines or therapists that their healthcare workers can report to, but everyone will say that no one uses that resource, or very few people will use that resource. Exposure to trauma, pandemics, conflict, displacement, wars, it's like name it. So there's an intersection of personal, institutional, and systemic stresses. What are the solutions? Individuals and teams, and this is something that I've seen already happening here and already being talked about. So peer support, debriefing groups are fantastic, excellent. Reflective check-ins, 10 to 15 minutes weekly. I also tell leadership that when you send messages to your healthcare team, then they should always be in a ratio of 3:1. So 3 optimistic, happy, congratulatory messages to 1 critical message, right? So 3:1 is the ratio. Please keep that in mind. Mindfulness and self-regulation training, recognition and autonomy. So small wins. Team ownership is extremely important. There is no one single person who's doing the job. It's always the team. And if the teams can be given agency of that and empowered to say, we did it, really helps with burnout. Building community, we're in this together. Think low-cost, culturally adaptive approaches. We've been talking about innovation and technology, but I think Maria and I were talking yesterday as well that innovation is not equivalent to technology, right? Innovation is from the word nova, new. So that's like, how do you renew yourself and think outside the box? And some of those solutions can be really, non-technologically based and just culturally adaptable. At institutional level, you guys are already doing it. So again, kudos to you all. Leadership training and empathy and communication. Workload reviews and fair task sharing. Integrate well-being into quality improvement. So that becomes part of your KPIs when you do quality projects. Okay? So what the pulse check on the well-being of the team. Create psychological safety so people can talk about whatever that they're struggling with in a safe space without feeling that they're going to be judged. Include well-being metrics and performance indicators, and build community, which is the we're in this together. Important to understand that you can't yoga your way out of a toxic workplace. Okay, people will say, go do yoga, all right? Or we'll have you just can't do that. Institutions must act. So you put in your systems, and here's that yoga pose with a to-do list down there, right? So it doesn't work. It absolutely doesn't work. And at policy level, of course, embed health worker well-being into human resources for health policy. It has to happen at the policy level. National health workforce surveillance should also include burnout. Donors and NGOs should require well-being components in funded projects, task shifting and team-based care to reduce overload. So again, nothing, it should not be an afterthought. Everything should be plugged into the design of whatever you're building. I do think, though, that there are some things that you can do within yourself, and I'm just going to take a couple of minutes now, while the system is shifting and while the system is setting into motion. And I like circles. Circles help you sort of, complete. It feels like things are coming full circle, but things that you can do to help sustain meaning when the systems lag behind. Emotional intelligence basically means that all of us have emotions. That's a normal part of the brain function. But how do we manage our emotions intelligently? How do we read ourselves? How do we read the room? Self-awareness, self-regulation, motivation, empathy, social skills, those are all part of EQ. It builds resilience and improves communication. and enables compassionate leadership. Ikigai, I'm sure a lot of you know about Ikigai. If you don't, please go and read about it. Fantastic, brilliant Japanese concept, meaning what is the reason of your being? Why do I exist? So every morning you wake up to figure out that at the intersection of what I love, what I'm good at, what the world needs, and what I can get paid for, somewhere in there is your sweet spot, right? And reconnecting with Ikigai, it renews your motivation, it renews your meaning, and it helps shift the focus from burnout to fulfillment, and it also allows you to leave when you feel that you're not in the sweet spot. I need to get out of this space, right? So for example, my Ikigai, I know, is relationships. That's what works well for me. I love it, I'm good at it, it gets me paid because I do mental health, and the world needs it, right? So helping understand yours is good. Very quickly, circle of influence. Inner circle is what you can control. Outer circle is what you can influence. Beyond circle is what you can't control. Don't waste time on it. Don't waste a lot of energy on it, and figure out where what sits in your life, right? So this is something I can control, and this is my circle of influence. Beyond that, not for me. And my last thing, again, we were talking to Maria last night about this circle of comfort. We need to step out. If we constantly stay in our circle of comfort, that results in burnout, right? So out of your comfort zone is your fear zone, because you've never done it before and you're a little bit scared that, do I want to do it? Do I want to touch it? And then if you're able to get past it, you get into your learning zone. And then comes the growth zone, which is your growth mindset. And what is important to understand is that once you're in that growth zone for a few years, that becomes your comfort zone again. So now you got to shift again. You now got to get back into that cycle. So if you are able to understand that and work with that, it really helps prevent burnout. Find your inspiration. Here's mine. There's my family, my friends, my circle of absolutely amazing women who are doing fantastic leadership work around the world. And right here, all of my mentees and my trainees that are now doing much brilliant work than I've ever done in my life all over the world. And that is my inspiration. So important to understand what your inspiration is, hold on to that and find your joy in that. I'm going to stop. Key takeaways, of course, burnout is a system problem, not individual weakness. Well-being is equal to patient safety. Small team-level actions can spark system change. Invest in emotional intelligence, purpose, and community. Thank you.
Thank you, Dr. Aisha, for an amazing session there. Can we have Tayo to moderate this session? There we go.
Thank you. Good morning, everyone. My name is Tayo Akins. I sit on the Evercare platform on the governance side from the Nigeria, Kenya, and Pakistan. So, Dr. Mir, you talked a lot about burnout as it relates to organization. How much of that is work-life balance in terms of how do you balance work-life balance and burnout?
So I may have a bit of a controversial response to that, because I don't think there's anything like work-life balance. What the best that we can do, I think, is what I call work-life integration. That how is it that you can, because, people say work and life, but for example, if you look at me, my work is very much a fundamental part of my life. And whatever is outside of work is also sometimes a lot of work. Like kids are a lot of work. Husbands are a lot of work, right? Families are a lot of work, and vice versa. So I think that it's important to see that how is it that we can integrate the two of those things. So for example, I can give you a quick example that when when the kids were little and I would travel quite a bit for work, I would or my daughter would insist on being part of whatever I was packing for my conference. And every morning she would call and say, today I want, what is your presentation that you're doing? Today I want you to wear that because that would fit best for that kind of talk. And, send me a picture after you've done it and stuff. So she was integrated into, even though I was away, she was very much integrated into whatever work that I was doing. So finding creative ways, standing desks, you integrate exercise, at your workspace, you bike to work, things like that, one can integrate the two together.
And there are a lot of students in here, and we talk about work-life balance, but there are a lot of innovators who are going to transform healthcare. What are the key takeaways that they can hold on tangibly that they should worry about not burning out?
So I think that healthy life habits need to start very, very early. And I say this, and I'm sure people who know me will say that you have none of them. But a good night's sleep, for example, doesn't cost any money, but there is excessive, very clear evidence that works to help with burnout. Exercising, of course, helps with burnout. If yoga, meditation works for you, or picking up something that you do to feed your soul outside of your workspace. So if that means reading at the end of the day for 10, 15 minutes, if that means music at the end of the day, if that means art, if that means kickboxing, but something that feeds your soul, that's not part of your day-to-day job, that works immensely well in terms of preventing burnout. The other thing that these are students and, sitting here, all the Gen Zs, there are two new terms that I recently found out that have become very popular with them. One is quiet. I want to have a reasonable life with, working these many hours. So I think that if that's what works for them, then that's what works for them. I think institutions and systems now need to shift because those are the people that are going to be joining us in our systems.
One last question for me, and then I'll turn it over to the audience. Yeah. There is an Elon Musk in this room. Do you think Elon Musk have a work-life balance or a burnout?
Do I think that if he has...
Do you think he has work? Does he believe in a burnout?
I think he has much bigger problems than it's like work-life balance and integration. And I think somebody was talking about if there was a spaceship that could take some people to Mars, who would you send? And that person was like, Elon Musk would be the first one that we want to send away. So absolutely.
Good deal. All right, I'll open it up to the audience. Any questions?
Talk, very important to all of us who especially deal with the patients all
Dr.
the time.
Can you bring it close?
Yeah. Can you hear me now? Okay. Yeah. So my name is Dr. Huma Majid. I am a surgeon by profession, and I've worked for over 40 years now in the medical profession. I'm very fortunate. I haven't felt the burnout as yet, but because I think there is a comment that it's the value versus the blame thing. What has happened is, over a period of the last few decades, physicians, I'm not talking about other groups because they are equally important, but I'm basically talking on behalf of the physicians. The value of their work has gone down and the blame has gone up. So, for example, starting from if you start, a clinic runs or starts late, who will be blamed? The doctor. If it runs late, who will be blamed? The doctor. If the surgery lasts longer, who will be blamed? The doctor. If it's somebody, there's a table death, who will be blamed? The doctor. So at every level, though you need a lot of support, and there are many people who are involved in the process, but it's the doctor who takes the face, who faces the physician, the management, and also the patient's attendants and the patients. So I think that I personally think that every hospital should have a physician support officer as well, who should be looked into things rather than just a patient relations officer. You should have a physician support officer. And that is extremely important to protect your people from attrition and migrating to better systems. And that's my comment, and I don't know. I would like your point of view on that.
I agree with you, Dr. Umar. The buck stops with the doctors. So at the end of the day, somebody was talking yesterday about how for a doctor there needs to be 6 to 7 other people that support that job, that opens up those jobs. So agreed, absolutely agreed. But I do think that, again, when we talked about the systems, that resilient systems need to be plugged into place, that if the other things are working well, from the minute that a patient actually reaches out to seek care, from the first phone call that they make, if things are working well and there's communication at every point in time. So if there is a delay, there is proper communication. If there is an adverse outcome, there's proper communication. Then, patients generally tend to be a lot more pardoning to the whole system because they know that they've been taken care of. But unfortunately, this is part and parcel of the work that we do, that sometimes there would be adverse outcomes. So that piece of continued transparency, as Jide also mentioned, and communication at every stage really helps with shifting that blame from just that one point person.
Any other question?
Hi, can you hear me? Hi, my name is Dr. Taimur. I'm working as an emergency consultant at Evercare Hospital, Lekki. I am really glad that you spoke about this. And this topic is very dearly to me. I worked through the COVID crisis in London in the crumbling NHS at that time. And I would just like to emphasize that the most burnt out clinicians in the hospital are the junior doctors, and they're the most underappreciated ones. And there are a lot of junior doctors, junior nurses, and medical students here. And one of the reasons that this topic is very dearly to me that I've lost a very good friend, I've lost a very good colleague to burnout during the COVID. The early signs of burnout need to be appreciated early. And so you keep ignoring burnout until one day it hits you, and then you realize that you can't be functional anymore. So if you feel like you are having the early signs of burnout, and I would like you to shed some light on the early signs of burnout in the clinicians. If you recognize that you're having any of those signs, then please speak to someone who's your senior, or to speak to someone who in your organization who is looking after your mental health well-being. So basically my question is, can you shed some light on the early signs of burnout in clinicians, please? Thank you.
Yeah. So thank you for that. And absolutely, physician depression, physician anxiety, physician suicide is a big thing. Healthcare professional suicide is again something that they are at a high risk population for suicide. And I will talk to everyone that I can that it's so integral to take care of your brain health. Right? I don't even use the word mental health because then everybody, there's such a stigma attached to the word mental health. So it's your brain, the most important organ in your body. Take care of it. And as soon as you figure out that perhaps there are changes in sleep pattern, there are changes in your mood pattern, your family is telling you that their irritability has gone up, or you're more angry, or you're talking to us less, you feel that you're not able to concentrate at work, or there's fogginess, or as I talked about, exhaustion, depersonalization. It's very important to talk to a trusted person. And it seems to me that you all, with the work that has been happening through empathy training, you have champions for that, compassion champions, and go talk to them. There's no stigma, involved in that. I think people are so much more open now. around this whole space. But before it gets to a point where, to a point of no return, it's really important to pick it up and talk to someone who's a trusted individual.
Dr. Mears, most organizations also have employee assistance program, like you indicated before,
Absolutely.
and most of them do not even tap into it.
Yeah.
Just like he said, when you have it, it's relatively available, but people just do not tap into it.
Yeah, absolutely. So people don't go, people will use it for other things, but they will not even want to be seen going into that office because there's an automatic assumption that perhaps they're not doing well. But even for organizations, I think there's sort of a little bit of a responsibility to shift the culture around that they make sure when they say that they would not be penalized or they would be allowed whatever space that they need, then they do it. Look, it's important to understand that the money that organizations lose because an employee has either anxiety or depression is huge. So even if you are not thinking about that this is morally the right thing to do, it's also costing the organizations. It costs the world $30 trillion every year, mental health issues. So the cost is huge, and it's integral to for organizations to plug very robust systems in place that are not penalizing the employee.
Our time is up, but there's one last question up there.
All right. Thank you, Dr. Ome Friday, cardiac anesthetist and intensivist at Evercare Lekki here. Thank you so much for the wonderful presentation, but I have an observation to make. Here in Africa or here in Nigeria, a lot of things happen, and I'm glad a lot of head of institutions are here to really appreciate what I'm about to talk about. This stress in increasing financial burden ravaging the world currently. Thank you.
So thank you for that question, and very candid question. And I think that it's a tough one because, and I'm not quite sure if healthcare professionals are the only people in that space right now. I mean, because of the increasing inflation, because of even unemployment rates, even, the opportunities for employment are far and few. So if you decide that my current employer or a current place where I am, they're not paying enough, you don't have much choice in terms of looking for other spaces and other places. A lot of people will also talk about, outside of healthcare professionals, looking and doing a number of different jobs to be able to make it. But again, I think part of it, so a big responsibility, of course, lies on the employer to figure out that even if you can't increase the wages, what is the extra stuff, what are the other things that you can do to help your employees mitigate that cost burden on them. So for example, transport that you talked about is a huge one. With the rising gas prices, I think that if your hospital is able to, organization is able to provide transport, that works well. You don't have to drive to work. I mean, that in itself is like a big stress, going and coming back, just being in horrible traffic. Also, I think that partly it's also, again, system level, yes, but also incumbent upon the individual. As I talked about, thinking about your ikigai, thinking about your purpose, your space in life, that what is it that I truly want? Am I looking to earn this much because I absolutely need to, or because I feel that this is what is somehow what the other physicians might be making, or this is the kind of lifestyle that everybody needs to have? Do I also want it? What is it that I'm enjoying doing versus not? So just yesterday, I think, Maria, you were giving an example that, somebody reached out to you with doing some executive coaching hours with, for a few hours, and then you kind of said, Sunday, do I want to go out, have fun, or do I want to make money? And then decided that, no, I want to protect my Sundays, and I'm going to give up that particular opportunity that's come in. So I feel that those are important questions for people to also ask of themselves, that, how much is needed. Maria, you want to add to that?
In our days, thank you very much, Doctor. And it's very true that in our complex environment that the organization has to go through, there are many polarities. One of the polarities is how you are going to keep the well-being of your people, especially healthcare, and be profitable and have the cost down. This is one polarity that they have to go through leadership. And the most well-known, I think, polarity is innovation, vice versa, low cost, and again, profitability. This is at the organizational level. At personal level, I believe all individuals, they need to think, how important is my well-being and my mental health? And there are like boundaries. How many hours do you want to work? What is family life means to you? And there are many questions that they have to go through, the reflection that you mentioned that is very, very important. And I believe they need to balance it. And well-being and quality of work and family and all the aspects that make life important. That's my comments. Thank you very much.
Thank you, Maria.
We're out of time. Thank you.
Thank you very much for the very informative session. If I can call on stage Dr. Ayo, please. So before we break for a very, very quick coffee break, can I just recognize all those who have done an amazing piece of work around the abstract discussions. If you've submitted an abstract discussion, the free paper or the posters, please may you just stand up for a second. Thank you. So a huge thank you to you all for your time, your effort, your participation, for advocating good science at Evercare. So we're going to take a very quick coffee break, just 10 minutes. Please be seated in 10 minutes' time, either with or without your coffees, but 10 minutes only, please. Thank you.
hard, pray hard, pay dues. Ay, I transform with pressure, I'm hands-on with effort. I fell twice before, my bounce back was special. Let downs will get you, and the critics will tissue. But the strongest survive, another scar may bless you. I don't give up, no, don't give up, no, no, no. Nah. Don't give up, I won't give up. Don't give up, no, no, no. I'm free to be the greatest I'm alive. I'm free to be the greatest here tonight. The greatest, the greatest, the greatest. The greatest, the drifting from across.
Can everybody start making their way back to their seats, please? Can we please ask everybody to return to your seats now? Thank you.
The coffee break is officially over. Please come back to your seats. Can we please have the ushers moving people back to their seats, please?
My name's Mark. I lost control of my legs and went paralysed from the waist down and had to have a spinal surgery to recover from that and to get myself back together. Since then, I've been under care of Dr. Chris, who's been exceptionally good, and I'm now recovering quite well. At first, when I got here, I was in extreme pain. That was quickly diagnosed, and I had the operation, which went very well. And since then, I've been recovering well. The nurses have been very good. So I'm quite happy with everything which has happened here.
My name is Dr. Anele Christopher, neuro and spine surgeon consultant at Evercare Hospital, Lekki. So I was privileged to manage Mr. Mark, a gentleman who presented with significant back pain and progressive difficulty with walking. Within a space of 2 weeks, he wasn't able to move his legs at all. So we did a spine MRI and we found a huge tumor in the thoracic segment of his spine.
Well, as an expat, It's good to know that there is a very good hospital in Nigeria. That's quite a worry for some people, but I'm living proof that it actually works out well.
So he had a spine surgery through the thoracic posterior part of the back. So currently he's recuperating. The tumor was excised, having good recovery, and is even able to move his legs. Happens to be happy with the progress made so far and happy with the care he got.
But Dr. Chris is exceptionally good. I'm very happy. He was the one who did the spinal surgery, and everything has been done very well. And I'm recovering really quickly afterwards as well.
Today, Evercare hospitals are turning that dream into reality, delivering modern medical expertise right where it's needed most. For countless communities across the world, access to specialized healthcare was once an unreachable dream. Spanning Pakistan, Nigeria, and Kenya, we carry forward a profound mission to make world-class care accessible to all through state-of-the-art facilities, global expertise, advanced clinical practices, and compassionate, sustainable healthcare. At Evercare, quality and safety lie at the heart of everything we do. Each of our hospitals follows internationally recognized protocols, ensuring that every patient receives care that is safe, consistent, and world-class. We believe every patient deserves dignity, respect, and informed care, values safeguarded through strong governance and transparent communication that keep us accountable to the communities we serve. Our people are the foundation of this excellence. Through continuous learning, mentorship, and capability development, we are nurturing the next generation of healthcare leaders right here at home. But our commitment does not end at the hospital door. From free surgeries and awareness drives to disaster relief and sanitation projects, Evercare extends its care to restore hope and dignity across communities.
My experience in Evercare Hospital was outstanding. All the staff was very caring, doctors were very skillful, and I recommend everyone in Evercare Hospital.
Driven by innovation, we bring advanced technology and infrastructure to regions where access is often limited. From cutting-edge cardiac care to pioneering digital health solutions, we are redefining what is possible, closer to the people who need it most. And behind every recovery lies a story of compassion, teamwork, and trust. Together, as part of the Evercare Group, we are building a unified network of healthcare excellence, advancing access, improving outcomes, and creating healthier futures across continents. This is our journey, driven by purpose, powered by people, and inspired by every life we touch. Because at Evercare, we don't just treat patients, we care for communities.
In the heart of Lekki, a city that never stops growing, stands a beacon of excellence, compassion, and innovation, Evercare Hospital Lekki. Here, every life matters, every patient's story counts, to delivering world-class healthcare that transforms lives. At Evercare, we are transforming healthcare in Nigeria, one patient, one family, one community at a time. Access to quality healthcare should never be a privilege, it's a right. At Evercare Hospital Lekki, we make that right a reality every day. From preventative care to complex surgeries, we offer the full spectrum of trusted, specialist-driven healthcare right here in Nigeria. We are proud to be reversing the tide of medical tourism, ensuring Nigerians receive the same advanced care at home.
So now my baby can eat anything. She can swallow, she can eat rice, she can eat amara, she can eat apple, anything. So we are so happy. Evercare is the best. Mommy, clap for yourself.
At first, when I got here, I was in extreme pain. That was quickly diagnosed, and I had the operation, which went very well. And since then, I've been recovering well. The nurses have been very good, Well, as an expat, it's good to know that there is a very good hospital in Nigeria.
Quality and safety are not just standards, they are our way of life. Every procedure, every process, and every interaction is guided by international best practices and a culture of empathy. We are on a continuous journey toward global accreditation, reaffirming our promise of uncompromising excellence. At Evercare, patient safety is personal because we care deeply. Our patients are at the center of everything we do. We uphold dignity, respect, and compassion, ensuring every patient feels heard, understood, and valued. Our governance systems keep us transparent and accountable because trust is the foundation of care. At Evercare Hospital Lekki, your voice matters, and we listen. Behind every success story is a dedicated team. Through continuous learning and the Evercare Academy program, we nurture professionals who are not just skilled, but also empathetic, innovative, and purpose-driven.
ECAP, the leadership training program, has been very, very effective, life-transforming, because they brought real practical scenario, to the forefront. It wasn't a theoretical session.
I'd like to thank Evercare immensely for such an opportunity.
Good afternoon, ladies and gentlemen. The coffee break is officially over. Please move back to your seats. And we are going to start the next session right away. So for the next session, we are going to be having talks around digital health. And I would like you to invite with me to the stage the CEO of Cedar Crest Hospitals, Dr. Debo Odulano. Please welcome him.
Good afternoon, everyone. It's always interesting to do a session after a coffee break, because maybe the sugar is still moving around, but at least it's a coffee break. I'm Debo Odulano. Currently the CEO in digital tools as well as digital infrastructure to ensure that everybody gets a touch of, the value we're creating. My talk will be talking about my experience while at Evercare, my understanding of what has happened since then, as well as what we're doing right now at Cedar Crest by establishing a practical innovation sandbox where we test a lot of things through rapid iteration and try to launch them as soon as possible. I think one thing that is very important, just really to thank the Evercare group for inviting me to speak on this topic, is that while you're building progress in emerging markets like this, you'll be faced with a lot of constraints. And these constraints really are opportunities to unlock extra value. The constraints locally within the emerging markets are mostly around affordability, infrastructure, literacy, and most importantly, trust. And the trust issue is actually very sensitive because it's a continuous journey of trying to, one, build trust, but then also communicate and transfer that trust so that it kind of sets that fire that consumes everyone and pulls them together. What does it mean to deliver trust through digital health in the context that we operate, looking at the African scenario, looking at Lahore as well? I did happen to visit Lahore while at Evercare, and I could see that there was a lot of similarities in context. And I hope that we can speak about that here today. I think it was very important to note that the work we're really doing is not technology transfer or knowledge transfer per se. It's context transfer. It's seeing things that have moved the needle in one part of the world with similar context and bringing it to another context and trying to adapt it accordingly. So you would see a few things coming as commonalities for these areas. 50% of Africans actually lack access to essential healthcare services. And we're seeing a new trend where people are actually crossing borders, either state borders, national borders, to be able to get access to these services. But one thing that has become an essential tool in facilitating these processes has been the availability of digital tools. So if you come to Evercare, you would see things like WhatsApp access. So you can do a lot of things through the WhatsApp channels. You could do a lot of things through the mobile app and other channels. And then we're also integrating cross-border referrals and transfer of skills using technology as well. One of the most recent that I noticed before leaving was the ability to use the Evercare platform as a way to run virtual ICU rounds. The fact that we had skill sets in different pockets of the ecosystem allowed an entity that didn't have that much skill sets to tap from it in real time. So when we look at digital and building trust, we must look at the constraints closely. One of those major constraints really is low trust. Why does low trust exist? And if we start taking off the layers, we see that it might also be because we are not communicating trust. So when we start to achieve specific things, it becomes very important to also push that out. When we speak about C.K. Prahalad and the sort of philosophies he had around getting lower into the bottom of the pyramid, we start to see that these things become more important. Can we introduce micropayments to help people access the care services? Can they pay in installments? Can we share that we trust them? Because most times trust is actually very reciprocal. One of the best ways to build trust in your patient engagements is actually to invest trust in your staff. And we've seen this, obviously, with the Evercare group, with a lot of empathy being the center of the focus. If we can empathize with our staff, then we are essentially channeling that empathy through the staff to the patients, and this starts to build trust. And all of this can be achieved digitally as well with the support structures like micropayments that I've said earlier, telemedicine, and the core of all of this most times is interconnectivity. So like within our system, we use one EMR regardless of the location. So we're able to see what's happening in Lagos real time, even though we're in Abuja. We're able to see things happening in Kainji real time. We're able to connect and coalesce our supply chains for better access and value creation. With Evercare, we've seen that you're now using the same EMR across Lahore, Lagos, and the other hospitals, and that has a significant potential to drive the patient trust. You can now start to see that you're enabling patients to move across the platform as well, and that is driven by trust. I like to look at things from this point of view. The fact that when we divide the global population into purchasing power, we see that it's not enough to provide value, say, to tier 1 or tier 2. It's the constant innovation to drive the value downwards. And one thing is for sure, as you go downwards, the constraints increase, the distance to care increases, and the reorientation to actually take care to the patients becomes more prominent rather than expecting the patients to come for care. So, I like this work by Prahalad that says that you want to continuously provide world-class quality, improvements in performance levels, scalability, and most importantly, universal access. And we could see, if we look at all the things in this sandbox, that digital has a role to play, and we must start to look at things from this point of view. We can use digital to implement multi-pricing within one ecosystem, within one facility. We can use digital to fine-tune our organizational relationships, build our rewards and recognition systems. We can use digital to also improve specialization through e-learning, and I think we have a platform that is doing this across multiple countries and geographies, to a national platform that is trying to do this across states. And you'll see that obviously we're working within different constraints, but the central thing remains that we are trying to make life easier for the patients, and generally by creating value, meeting patient experiences, we are building trust, especially in digital access. We are a bit more about Cedar Crest. We focus mostly on orthopedics, and we can see that now over the last 17 years, we've started to see a greater trend of being able to provide orthopedic value that we can sell to both the Nigerians in diaspora as well as other West African countries. So that brings us to the real question: how do we get these people in? And doing it, really, we've established a few foundational notes. One of those foundational notes is discovery. We need to make sure that people can find the services that we offer. That's the first part of trust, of building trust in digital. Can we build very user-friendly, easily accessible discovery platforms that helps us to discover where the doctors are, what specialties are available, when Dr. Tahir is coming from Lahore, when Dr. Assad would be visiting Lagos, who is going to Kenya the next time, all of that, discovery. Can we make that discovery a bit more easy to access? So rather than doing mobile apps that we need to download, we're using shortcodes, we're using WhatsApp, we're bringing the AI agents directly to the clients on WhatsApp. We've played around second opinions, which has really helped to drive the referral culture and doctor-to-doctor trust. We've also played around, more importantly, microfinancing and micropay. I have a very interesting story to share around this micropay. We introduced a solution called EasyFin recently, and initially at the point of introduction, all our marketing said you can now pay for your healthcare bills in installments. For the first 3 months, there was no uptake. And it just seemed like there was a problem with the product. And then we decided to change it a bit, really trying to bring to bear the fact that we are actually doing context transfer. And we said, pay small for your healthcare. And the uptake went up. As a matter of fact, we started to see more people coming to speak to us about, how do I actually pay small? What does it mean? So the real problem was installments was actually not a very contextual term to use to communicate what we were trying to achieve. And if we dig into that, the digital adoption there was actually caused by the wrong communication. Right? So we need to keep that in consideration as we move. So there's still a lot to do, and it's an ecosystem play. We need to constantly look at ourselves as players within a wider ecosystem and try to see how to bridge this gap. There's a lot of work being done by the telcos. One, to be able to increase the access from the point of connectivity. If there's no connectivity in that area, we can be thinking about telemedicine or even digital access. There's a lot of work also by the insurance players that is helping to shape this up. But more importantly, we as the players need to continuously interact to find better ways to unlock the value that we're speaking about. I had examples around this, but I'm also trying to keep to the time. Case studies that have really moved the mark. A company called Evercare Health in Nigeria realized that the uptake for insurance was actually very low because people had to pay a lot and they couldn't get micro insurance or tailored insurance. So they used the data and started to do smaller packages that were more affordable and were able to create a lot of traction from that. We've also seen the case studies around Reliance HMO, who started doing pay monthly insurance and started making it easy for people to do digital onboarding. And digital onboarding is one of those areas where you actually have the right 2-3 minutes to build consumer trust. And it's very important that your user experience or your UI aligns appropriately. So yeah, I spoke about digital discovery and medical tourism pipeline. And the goal here really is to really look at the fact that once we increase digital access, we can get more patients locally from the diaspora as well. We can, use retention. We can use trust to drive retention, and the real outcome is more revenue, more outcomes being communicated to the public, and even more access. So we're close to it. The future is here. Connected care is here to stay. We're going to start seeing a lot more wearables, a lot more remote monitoring, and it's time to continuously collaborate to deliver value. Thank you very much. Would love to answer whatever questions you have. And
thank you, Dr. Debo. So we open the floor for questions, and I would like to call in Dr. Dami to moderate the session.
Excellent. So good afternoon, everybody. My name is Dr. Dami Collier. I'm a physician scientist from the University of Cambridge, but also run a digital travel health company that tries to help Africa-bound travelers, particularly diasporic returnees, navigate what is indeed a fragmented healthcare system. So lots of alignment I see with what Cedar Crest is doing. So really lovely to hear that. And a couple of things resonated with me. So the idea that, just extending your analogy of the bottom-up pyramid, is that trust is not and equity are not nice to haves. They're not just features, but are integral to the foundation of this pyramid that you're building. But also the idea of context adoption and how, if you do this right, actually, you do engender trust and increase uptake from these digital and innovative solutions. So whilst people are gathering their thoughts with regards to what questions they want to ask, I did have a question for you. So what governance models can individual institutions ensure that they have in place that ensure that inclusion is sustained, not just promised, in order to foster trust in what they're building?
Oh, thank you very much. I think that's a very great question to ask, because at the end of the day, I think one of the things that are very foundational in driving sustained change is cultural orientation. And I feel that's where governance has the strongest role to play. How can we as leadership or the governance structures that help drive organizations instill the cultures, the cultural perspectives that help people to see value in, one, delivering quality care, expanding access, and ensuring inclusion. It's one of the most critical levers, in my opinion. If you do not establish it from a cultural point of view, then it's hard to ensure that once people leave or there's fresh staff, that would be continued. The other aspect of governance, I would say, would be ensuring that adequate resources are actually provided for people who are actually trying to drive this change within your context.
Thank you. Do we have any questions from the audience? There's one at the back, but whilst the mic is getting to them, I was going to ask you, what do you say to the digital hesitant? So within COVID, we all saw that technology was used for good and used for harm, but a direct impact on trust between the general population and the scientific community. What do you say to the digital hesitant who don't want to take this journey with you?
Okay, so the thing with adoption is not linear. You would always have different groups of people during the journey of innovation, as I would love to put it. So you'd have those initial adopters, and then you would have the laggards, as usual. One thing that is most important for the innovators is that there are a few things that drive adoption. Trialability is one of them. Observability is another very strong one. And we need to couple ensuring that enough people, even the laggards, can get an opportunity to try the value that we're introducing. And once they try it, they can start to see how that value kind of fits into their lives. So that's the perceived use or the perceived value that they want to get from it. The other aspect is the observability. If this stuff is actually creating value, people should be able to see it. And if it's that we've created value, say, for example, at Avenue Hospital, and it's just localized, then we can't build trust on that. They need to speak about it. They need to showcase it in scenarios like this. And that continuously reinforces the fact that you are about to miss out on being one of the people who glean value from whatever it is that we're introducing. So the fear of missing out is one of those things to help pull laggards into the adoption curve earlier.
Indeed. I think we have a question in the audience.
Good afternoon. My name is Aisha Oguyemi. I'm a fourth-year medical student. Thank you, sir, very much for your presentation. Equipment are expensive, and the only thing that can get cheaper are the healthcare professionals or the providers. So how is it possible to make care so cheap without exploiting the people that are actually providing the care and making sure that they are adequately compensated? Like, who is paying the price? Like, who? Do you understand my question?
Thank you for your question. Very good question, I'll add.
Thank you very much. Very, very, very good question. Someone's got to pay. Even when we are doing the transition and you're trying to create that value and that gap, most times what happens is that you're either unlocking price performance and someone is going to pay. To unlock price performance, a lot of stuff goes into it. Training, change of the infrastructure, introduction of technology, and the likes. But really to bring it home, we have to start to rethink the roles that we play. One case study, for example, at the Shoulders Surgery Cancer Center, the hernia center in Canada, in the past was that bring the most experienced, the most efficient or most technical person and put him at the door. By doing that, you want to make sure that patients who do not really need to get into your system enter the system and start to consume or incur costs. So I'll give you two scenarios. There's a surgeon who is actually going to do the hernia surgery, screening patients at the door and sending patients back home. What this prevents is that the patient who would have typically gone to the receptionist, spent 10 minutes, gone to the vital sections, spent another 10 minutes, etc., has not incurred those costs for the organization. And you've kind of changed roles a bit to ensure that the costs comes down. There are many other tactics like that. There are scenarios in, say, the NH hospital where they've looked at it and said, Why do I need a cardiac surgeon to open the chest of a patient? I need a cardiac surgeon to work 1 hour on the heart of the patient. Can I get another member of the surgical team to tack shifts and take on these other roles? So it's really about looking at our dynamics, being very clear as to where we want to go, and trying to, work within those constraints to achieve it. One example I try to give to make this very clear to especially students trying to work in digital health is that one time in Nigeria, bottled water was an aspirational product. And the real cost of bottled water, or the real cost escalator with bottled water, was the actual bottle, the plastic bottle. And people started to walk against the bottle. They started with ice water tied into nylons that was giving people a lot of infections. And they eventually walked onto pure water, which is sealed in the sachet and very dead cheap, affordable, accessible, but still gives you, to a great extent, the same quality. It's all about changing specific aspects of the product we're selling to ensure that everybody who wants to get the product can get access to it within the constraints that they leave. Thank you.
Thank you so much. I like how those 2 last examples came right back to human touch points, so how integrated innovation in technology is with human input. Well, thank you so much. I'd like you to join me in thanking Dr. Debo Olulana for a riveting session. We'll move on to the other speaker.
If I can just call on stage Dr. Asad, please. So just before we move to the next session, Dr. Asad would just like to make a very brief announcement.
Yeah, so the announcement is actually a bit more dynamic than just the announcement. We really wanted to recognize all the great science that has come through this inaugural Evercare Health Conference. So we would like to recognize all those individuals who not only submitted abstracts, but also got an opportunity to present. So whether you submitted or you presented, if you're in this hall, could you please stand and come forwards? Is it okay if we get them onto the stage? Yeah, if you just come onto the stage, please. Come onto the stage. We want a group photograph. And for the rest of the audience, please, great round of applause for these guys. Fantastic work that's come through. And you can go see the abstracts, the digital posters in the hall outside. And I would also like to call upon the scientific subcommittee, if they were involved in reviewing these abstracts. If you're in the hall, please come up as well. And Dr. Ayo and Irfan, please join the group. Let's just get a group photograph, folks.
Thank you, everyone. If I can now call on stage our next speaker, Dr. Zaki Uddin Ahmed, from co-founder and chief strategy officer, Aman Ventures USA.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone, and good afternoon. First of all, I would really want to thank the organizers, especially Irfan Saab, for inviting me to this conference, this event. And I have to share that I'm really impressed, pleasantly impressed, surprised pleasantly. I did not have an idea, about the group and the vision and what you guys are already doing and want to do. So it's really impressed with that. So I will just quickly start because I think that time is short as always with the last speakers. So I'm going to talk about future of remote patient monitoring and engagement. And I'm big on engagement. That's why I've specifically mentioned that. And that's the model which we have been talking about, and we call it the hospital model. And next, please. So can I? Okay. Yeah. So who am I? Those who know me, they know that I carry a very busy card, and I'm known for a folded card. So I deliberately did not use that. I just want you to know who I am. So I'm a physician by training. I'm driven by mission, so I'm a why person. Purpose drives me. Whatever I do, I have to do it for a reason. I like to call myself strategist, and my middle name is collaborator, so I love to collaborate. I'm an entrepreneur, academic, I'm a professor of digital health, I'm a trainer and a coach and a mentor. And my work areas are, obviously digital health is my first love. I started working in telemedicine 28 years ago, and I'm sure that many of the students and the young graduates were not even born 28 years ago. And that was kind of an epiphany for me when I learned about telemedicine in the US, and I just decided that it's going to be my calling for the rest of my life. And I brought telemedicine to Pakistan, and ever since I've been working in telemedicine and, as we call it, digital health now. Patient safety and quality healthcare. I've established an Institute of Patient Safety and Quality Healthcare in Pakistan. Again, established an organization which is working to develop health research ecosystem in Pakistan and the region. I work a lot in healthcare leadership. I'm a certified trainer of 7 Habits of Highly Effective People, and help leaders in their journey of self-development and leadership. So I assist them in their journey. And my recent love is lifestyle and functional medicine, because I want to create health and shift the sick care system to a true healthcare system where we create health. So why do I do what I do? So that's, that's my why. Serve patients. So we all healthcare professionals, we got educated, we became physicians or nurses or managers only for one purpose. So our raison d'etre is to serve the patient, period. And I want to improve the health system and create health. So this is a slide which I added, and I want to tell you that, so we organize Pakistan's largest health event, which is Health Asia, every year. We've been doing it for the last 22 years. So the 21st Health Asia, we started giving awards. And we were looking for the best, or a CEO, obviously there are others as well, who we could give the award to. And Irfan Saab was selected, and I'm so happy and delighted that we did select you. So the decision to award you with the best CEO, I think that was 100% correct. And we had other leaders also. So thank you for being with us. So just a quick situational analysis. Where do we stand? This is healthcare, unfortunately. So we have to admit the healthcare is struggling, if not failing. So look at all. So we are struggling in all of those 5 areas. So that's not good news. So, we've not been doing, whatever we've been doing, apparently it's not really working. So we start from there. So this is Professor Lu Xian. He's a professor emeritus at Harvard, pediatric surgeon, father of the modern patient safety movement. And look at what he says about healthcare. And the statement that we haven't figured out how to make that work well really drives me and all what I do in healthcare. So we have to be humble that healthcare, in healthcare we are still struggling. And we have not been able to create that value which we were responsible to do. So the current healthcare system is unsafe, expensive, inaccessible, inefficient, and ineffective. So we need to do something about it. How many of you have seen this slide before? Any hands? Okay, 1. So this obviously is my favorite slide, and I want to show this slide because I want. And what do you see in this slide? What is the most remarkable thing in this slide? Anyone? What is the most remarkable observation you can make in this slide? So this slide, since I cannot hear you, this slide was, this is a radio news. Look at the date, 1924. Even television was not, born yet in 1924. My father was not even born yet. Yet there were some crazy visionary people who believed that there would be some kind of technology which will be used to create a connect between physicians and patients. They didn't even know what technology that would be. And that's what we are doing. So even in 1924, 101 years ago, there were some visionary people. So telemedicine or digital health is not new. So I just want to show you these slides, and I'll quickly skim through these. This is not a new concept. But since healthcare has a lot of inertia and bureaucracy, and the adoption has been historically slow, we still have not, the uptake of technology or digital health is still not there yet. So this is how the whole paradigm has shifted. So on the left side is the previous healthcare model, and on the right side is the new or the current or the futuristic model. It's a complete paradigm shift. It's a busy slide. I cannot wait on this, but it'll give you a sense of what I'm getting to. So we have e-physicians. This is Eric Topol, one of the leading cardiologists in the US. He runs his cardiology clinic with all of these devices for the last 10 years, not 6 months, for the last 10 years. He's very, very famous. He conducted the world's largest and the first study on remote patient monitoring devices. So we have e-patients as well. More than 80% of the patients go to the internet before they go to physicians and on their way back. We have the Generation Z. We know how telemedicine works since I have less time. So do we have the digital pill already? Yes, we have. And this is the world's first digital pill. So technology has been there, not something new. I'm not telling you or our colleagues, we're not telling you something which is fairly new. So wearable sensors, pretty much all kinds of wearables have been out there. And right at the bottom, this is John Sculley. John Sculley is the ex-CEO of Apple. And we were in the same conference speaking, and we were at the same booth. And look at the smile on the face of the most innovative company's CEO. He was like, wow, what is this? Healthcare, innovation. So that's where we work in. So I'll just skip this in the interest of time and move to a few points before I start, with the remote patient monitoring, So this was historic, right? The CEO of Google, the largest IT company, came up in front of the world. What did he say? The first thing he said was health. And the second was AI, period. And then he goes on to say what they had done already, predictive analytics. This was 3 years ago. So we know radiologists are becoming redundant unless they redefine their role and adopt AI. I witnessed this launch of the WHO, AI-based nurse. So what is the future of healthcare? When you say future of healthcare, what comes to your mind? Think about it for a second. So the future is actually already here. It's connected health. So we have never been connected the way we are today in the history of humanity. We are all connected. But the question is, are we connected in healthcare? I think that's the question we all need to ask ourselves, and that's what I'm going to talk about. So connected health is proactive, not a reactive. Sick care is reactive. Patient-centric care by monitoring and engaging patients remotely. Simple. So we call it the Uberization of healthcare. And remote patient monitoring and engagement shifts the sick care system to a more proactive and a continuous continuum of care model, which we require today. These are the different benefits of RPM and engagement, and you can appreciate and recognize all of them, that this is what we need. And that's why I started with Professor Lucian's slide. We need to make healthcare more effective, and we're not doing that. All of the chronic diseases, not most, all, these are 9, 10 chronic diseases, all of them are on the rise. None of the chronic disease has gone down, let alone eradicated. So we need to do something better. So this is the model which I have presented across, and we are working on this. We call it the hospital model, and the 4 factors driving this model or leading towards that. So hospitals, we have talked about workforce, it's a big thing. WHO is talking about it. Hospitals are unsafe. WHO says more than 10% of patients are harmed while in a hospital. And those figures are from the West. Pakistan and Nigeria, it's around 25 to 30%. We work in patient safety, and we know it's embarrassing. In our watch, patients are dying, not because of cancer. They're dying because of our systems and our culture. So the patients on the right side, Gen Z is not going to take this inefficient model of waiting 6 months, driving 3 hours, waiting outside for a 5 to 7-minute consult. They're not going to take that. And technology is there. Technology has always been there, always been ahead of healthcare. And the chronic disease burden. So all these factors, they tell us we need to move towards hospital, and I'm going to give you evidence on that. Anyone seen this slide before? It's a very famous slide on the internet. You can look it up. So that's how healthcare used to be. And you can see empathy on the physician's face. You can see it. And the physician is visiting the child. So this is how it used to be, doctors and house calls. And the child did not go to the doctor. So we have to go to the child. We have to go to the patients. And this is McKinsey's slide, so don't hate me for saying that. I didn't say that. McKinsey is saying that. Whenever I put this slide, a lot of people stare at me. I'm not saying that. I'm just, the messenger here. So hospital is dead. And look at the factors which are driving that death, which is not there yet. So we all know that a lot of, services can be shifted out of the hospitals. We all know that. Even the American Hospital Association, the custodian of hospitals, is endorsing this concept. So there must be some legitimacy. Okay. And this slide tells us how much of services we need in the hospital and how much can we just offload, So this is a very, very unique model in the Netherlands. So I'm just showing you that, there are various models which are working in the community and at home. So hospital at home, again, is not a new concept. It started at Johns Hopkins many, many, many years ago. Again, there were visionaries. They realized that we simply cannot sustain the burden of healthcare by just simply bringing all the patients to the hospital. We simply cannot do that. So Johns Hopkins took the lead and started this concept. They called it hospital at home. And now the whole world is following that. And this is my favorite statement. Clearly, if hospital at home were a drug, it would be a blockbuster if driven by the pharmaceutical industry. But unfortunately, it's driven by physicians or healthcare managers, and we have failed in that. So Mayo, Kaiser, and other hospitals and groups are actually working on this. This is the model which we built in Saudi. So I was the director of digital health at King Saud University, which is the largest university hospital in Saudi. And that's how we built the hospital model. And this is the project which we built there. This was the world's first completely integrated connected health model with 7 devices, patient encyclopedia for education, and a lot of other features. We called it Raha. Raha in Arabic means comfort, but it stands for remotely accessible at home. And we published that, and we showed to the world that in the largest hospital group in Saudi, this works. And I'll just give you one example. So the bariatric surgery department, which is a center of excellence, patients from all over the region come there. They approached us and they said, can Raha help our bariatric patients? Because we want to send off those patients right after surgery. And we did. So we worked with the department, and for every patient, we sent the patient the same day so that they did not stay back in the hospital for 3-4 days, saving $3,000 to $4,000 to the hospital/government on each patient. And that's what is Raha. So I'm a strong proponent of education, engagement, and empowerment of patients, and co-creation, bringing patients as partners, not as recipients of instructions, which again is the inefficient model which we physicians have been enjoying, I would say. So this is a Raha 2.0, and obviously the technology has changed on this. So Raha was built right before COVID, 16, 17, 18, so the technology has changed. Now we have wearables, and I'm going to show you those wearables. So we are using this term app as a prescription. That's what we need to. So in addition to writing, tests and drugs, they need to start writing mobile applications or digital therapeutic applications. So these are the different features of the model which we have created already. And if you look at that, it's a very comprehensive platform. It's a platform which connects patients wherever they are, not only at home, whether they're traveling. So I'm traveling here, and I'm wearing the world's first blood pressure monitor. It's an FDA-approved device. And not only that I can monitor my blood pressure in my own phone, but my physician can also do that. It's simple. The technology is already there. Are we using this technology? Have we adopted to it? I don't think so. But you look at all the different features. So these are the 4 digital therapeutic areas we are focusing on. And as you can see, coming from Pakistan and same in Africa, these are the biggest burdens for us, for all of us. So cardiology, diabetes, respiratory diseases, and mother and child care. So these are the devices which we are working with right now. And I just brought those here. Maybe we can look at those devices in the discussion. Again, this is the world's first ECG patch. Now just imagine that I can monitor a patient putting this patch, simple. And for 7 days, and the patient can take a shower, go wherever he or she wants to. So these are the devices which we are, working with. And I'll move forward. And this is the service which we've launched in Pakistan. This is the first time in Pakistan that we're offering Holter monitoring for more than 48 hours. So the 24 hours to 48 hours was the maximum. We are now monitoring patients currently for 7 days at a stretch. So imagine the value. And this is the process. I'll not go into the process. And these are the different ways we are doing it. So these devices not only measure ECG, we get a lot of other information which goes into our software, which also has AI, and it analyzes. So these are the dashboards which physicians are looking at wherever they are, and the nurses are also looking at. These are the applications, no need to discuss in detail, but every app has those features. So we are empowering patients so that they can actually take care of their own health themselves. So that's the empowerment which we are working on. And so these are the hospitals we are already working with, Tabba and South City. These are the 2 top hospitals of Karachi, and the others, we are just starting with them. So my last 2 slides, what do you see here? On the left side, you see how the stethoscope was invented, right? A tube. And it remained like that for around 150 years. And on the right side, you see a device which was recently launched, I think 2 weeks ago or 3 weeks ago. FDA approved the stethoscope, which not only, it's kind of like this, which not only takes, obviously, the murmurs and the auscultation does, but it's AI-based. So it tells you the whole, it analyzes the auscultation, gives you the murmurs and everything, and then when you put this device here and start talking to your patient, the same device becomes an AI ambient device. And it captures the conversation, converts them into SOAP notes. So this is but if you look at the transformation, the last 150 years, the transformation was not so disruptive. But the last couple of years have been completely disruptive. And obviously, that is the basic reason for it is artificial intelligence. Because, the BP cuff, which we have been using for I don't know how many years, the only reason why we can have an AI-based band is artificial intelligence, because it can actually, analyze that. So my question is, what is the future of RPM? Which wearable, and this is a thought which I want you to go back with, because we cannot have the patient wear 4 or 5 different devices. We are moving towards a one single device which will capture everything. Even today, we have these devices, so they're capturing like 4 or 5. So I brought a watch, which is not FDA approved yet. It's a company from California. And by the way, we are not selling them. We are just working with them as partners. They have filed for FDA, but they have actually created a watch which can measure blood glucose, and it's non-invasive. So we are integrating that as well. So are we going to have rings? Currently, we have Samsung and Aura and a few others. So are we going to go for rings, watches, patches, implants within the body, clothing? So that's a question which I would want to leave you with. And maybe next year when we gather, maybe we'll come up and we'll show you that yes, we have one wearable which does all of that, and we are using it for our home hospital model. So thank you very much.
Thank you, Dr. Zaki. If we can have Dr. Dami to come and moderate, thank you.
Good afternoon again. I'm Dr. Dami Collier, and I just want to thank Dr. Ahmed for that tour de force of the historical perspective of digital health evolution.
My pleasure.
And some of the things that struck me, actually, were the idea that remote patient monitoring isn't just about gadgets and gizmos, really. It's a real paradigm shift in the system from hospital care to home hospital care. That's a really lovely use of the word. But real transformation happens when technology is aligned with policy, workforce capabilities, trust, and innovators. So there are lots of students in the room, and really for their benefit, because in our society, necessity breeds invention, and these are the minds that are going to be developing these next tools that can serve our populations. But I'm going to throw your last question back at you. What do you see as the immediate opportunities in remote patient monitoring that will improve people's or patients' experience?
Yeah, so I just want to mention that the policy is already there. So even in the US, which is a very regulated market, this is already being reimbursed. So they want patients to move out of hospitals and stay away from hospitals, and they're reimbursing it. The virtual wards in UK, Saudi Arabia has its own virtual hospital. So we are moving towards that, and the policy and the regulation is supporting that. So just wanted to mention that the question which you are asking about, I think I would not focus only on a device. I think it's a mindset where we need to focus on creating these platforms through which patients and the families can remain connected. I think the important thing to remember is connectivity. Because the moment the patients in our current system, the moment the patients leave the clinic, they start freaking out because they feel that, okay, what's going to happen? If I have a question, who am I going to ask that? If something happens, who I will contact. Yes, we have call centers in hospitals, but they're not really connected health models. So I think for the future, for the students, I think that's where innovation, the opportunity of innovation really resides. Devices are being developed by the industry with a pace which we cannot match. And it's very expensive as well. I feel that I think the rings has a very strong future. But then again, we don't know what we don't know. And one thing which I've learned after studying artificial intelligence is that AI is a different beast. As I mentioned in one of the other sessions, we have invented an inventor, and since it's smarter than us, we simply cannot tell how it's going to create the future health and the devices. So I would rather have the physicians and the students focus on creating platforms where they engage with physicians rather than getting excited with hardware, because hardware is just, I think, would be a tool to achieve the ultimate goal. And the ultimate goal is to keep the patients connected with the physicians and the nurses and the care providers, and having them not to come to the hospital and do whatever they want to do.
That's a great answer. Do we have any questions in the room? Prof. Salim, can we have a microphone to the front, please? Just need a microphone.
Yeah, thank you. Very interesting and provoking presentation. So, one of my questions which I sort of raised earlier is this whole question of do you actually wait to see whether technology, especially AI-driven technology, is actually moving before you take action in Africa? Because I think at some level, it's just a personal observation, is that we are waiting for this evolution to take place. My strong suspicion is that we need to be engaged in it right now to really fundamentally understand it. And you mentioned that let's see where this thing drives it. My big fear is that we should not let it drive us. We need to figure out how do we deploy all these AI innovations in a way that's of value to us as humans and as patients. So that's sort of one question. And the other one is, in North America and Europe, the systems of reimbursement are so well driven that providers can segment a portion of it and use funds for hospital at home. We don't have that capacity in Africa. I mean, we can barely have patients taking care of their own needs in primary health care. So how do we deal with this whole issue of reimbursement in a way that's meaningful for us here in Africa?
Okay, so Africa and Pakistan, where I come from, we are pretty much the same. We have the same challenges. And I'll pick the second question first. I think what I see is that, when you make patients empowered, when you make them partner in the conversation, as opposed to just a recipient, when you empower them, when you give them the responsibility and let them drive this in the partnership model with the physicians and the nurses, I think they really add value, because it's all about themselves. They have access to knowledge already. The knowledge is not limited now to the physicians. It is democratized, it's available out there, and legitimate, proper, authentic knowledge, information is available, which the patients and the families are already, have access to. So I think we need to open up rather than, with a closed mind, which we had practiced in the last. So, Marshall Goldsmith, who's one of the leading, coaches in the world, his book is What Brought Us Here is Not Going to Take Us There, right? So first of all, we as leaders, we need to realize and be humble that whatever we have been doing in the last 50, 60 years, that's not going to take us in future because of the changing, behaviors of our consumers. I use the word prosumer. So prosumer is not a consumer. Prosumer is someone who simply does not only use the service, he or she is part of creating that service. So patients should be considered as prosumers and as partners, and we will see that they will add value to that. Coming back to the first one, artificial intelligence, as I've mentioned, so I've been listening to Jeffrey Hinton, who's the father of AI, who gave up I've been listening to Mo Goddard, Mustafa Suleiman, and a few others, and all of them have one thing to say. Even today, ChatGPT has an calculated IQ of more than 160. Einstein had an IQ of 160. So imagine Einstein talking to me with an IQ of, let's say, 70, 80. I have no clue what he's saying. And imagine artificial intelligence, which is growing exponentially. So the next version will have an IQ of 1600. So a tool or an application or a technology or something which has a mind of its own, if it has an IQ of 1600 or 16,000, we have no idea. And that's what, Hinton and Moorad say. So if it's a superior being. So yes, as I said in my talk, physicians or nurses and medical students, by the way, for sure, we need to redefine our role so that we don't become redundant. That's one. Second, we need to understand how AI is moving forward. And if our focus is patient-centric, if our focus remains that we exist to serve the patient, then we are going to ride with the AI development, right? But I still believe that AI is going to lead that because, as I said, we have invented an inventor. And it's really, really scary. It's perhaps the biggest existential threat to humanity, which we have never seen in history. So God knows what's going to happen in the next 3 years when we really have agentic AI in our hospitals. I don't know what is going to unfold. So let's be prepared for that.
So a lot to think about there. Do we have time for one more question? Please go ahead.
Hello, good afternoon. Thank you, sir, for all you said. My name is Victoria, and I'm a nurse in Evercare Lekki, LPD nurse. My question is, I have an interest in digital health. What are the pathways I am to take to become someone in your field? I guess that's my question. Thank you.
Okay, career advice. So yeah, again, the same narrative. It's out there, right? Yes, you can do masters in health informatics, you can do masters in digital health, but not limited to that. The knowledge is out there. I am a very strong believer of a mentoring program. Identify someone who's a champion in digital health around you in Nigeria. Identify someone and then make him or her your mentor. But you have to be very careful in selecting the right person, because if you select the wrong person, then the mentorship program really does not work. So I'm a big fan of mentoring and coaching, but on a long-term basis. So find someone who will guide you. There's ample, there are courses on Coursera, there are videos, learn from the gurus. As I said, I'm not an AI expert, but I've been listening to these gurus for the last so many years, and they have really helped me to understand, where we are. So go to the internet. If you can have a formal degree, go for it. As a nurse or as a physician, doing a master's in business administration or marketing or health management, or even AI. So one of the leading radiologists in Pakistan, the top one, did a one-year program from Harvard. He spent a lot of money, and he's a very young guy. But he realized that he will become redundant as a radiologist if he does not, ride this AI wave. So get a degree, but not limited to a degree. Find a mentor, and then, get the mentorship from that right person.
Thank you so much. I'm afraid we're out of time, so join me to thank Dr. Ahmed.
Thank you, Dr. Zaki. Thank you, Dr. Demi. If I can call on stage Jide to present the award, please.
So pleased to be back here with you. One of the things we wanted to do was to really give you some of the key takeaways. So this is really not in exactly the perfect order I would have liked it, but it's important just to give you a quick background. So I'll go through it fairly quickly. So part of the whole process at last few days has been in terms of a unifying vision. We underscored the whole aspects of connected care. We discussed healthcare transcending borders, which is not just a theme, but a call to action for collective transformation across emerging markets. So that was a critical piece. We also reinforced Evercare's role as a bridge between countries, disciplines, and institutions, redefining healthcare delivery through collaboration, technology, and empathy. Interestingly, we brought together 500 leaders, clinicians, students, innovators, and investors, and definitely signaled a momentum for shared progress in global healthcare. Now, some of the major themes and learnings, innovation, technology, some of the key things we discussed was that emerging markets are leading innovation in their markets. So we're not really waiting for any specific innovation coming our way, but we're leading it. We discussed technology and digital in closing the gaps in access and equity. We had a very robust discussion over the last 3 days on AI, telehealth, remote patient monitoring. We just had a very provocative discussion right now in terms of what's happening with remote patient monitoring and the whole patient empowerment. So that again was very provocative, the whole question of the empowered consumer, prosumer. So that's an important contribution there. Patient safety, quality of care, we had safety, quality, stemming from staff engagement and systems thinking and culture, strong panel discussions, very robust discussions on how we actually do that. Evercare Hospital showcased the leadership in creating a learning culture. So that was again a very important contribution we had in terms of how do we create a proper learning culture. We had clinical excellence panels, lots of discussion on integration of empathy. And again, I think that was a major contribution in this conference was the whole aspect of empathy, family communication, as core safety enablers. We had a leadership roundtable where we actually brought different leaders from different institutions. I'm struggling with this wind here, or rather the air is forcing everything, so just bear with me. Emerging leaders and partners, we discussed ECAP, Human Care X, again, whole question of empathy, coaching, capability building. Really important contribution to really define healthcare leadership pipelines. How do we actually create leaders? So we discussed that platform. Health system strengthening, again, we had strong discussion around how we develop resilient, equitable, patient-centered systems. Private equity is a framework. Again, you heard from the owner, TPG, how TPG looks at the platform they've created. And their question of values of integrated care and affordability shows the values they have. And it really differentiates this particular owner from other typical PE investors. Practical models we discussed in terms of integration of public-private partnerships. We discussed workforce and governance reforms to ensure inclusion and scalability. We discussed equity and patient experience as the North Star of system design. We spent quite a bit of time on cross-border collaboration and policy. Again, the keynote from the Nigeria CDC was very clear that we have to work on a regional cooperation in terms of health security. And again, it's very clear, pathogens don't respect borders, so that whole question of infectious disease control, emergency preparation is really important. We also discussed how collective intelligence and resource pooling across Nigeria, Kenya, and Pakistan can accelerate health resilience. We had good examples of how exactly that collaboration is taking place, how the inter-country learning and collaboration, especially we discussed with bariatric surgery. So a great example of how those collaborations add real value across all countries. Voices from the field, we discussed frontline innovation showcased through health talks. We had a lot of health talks, renal, we discussed cancer care, ICU transformation. So again, a lot of practical innovations on surgical collaboration across countries. We had nursing and allied health sessions to demonstrate the interdisciplinary collaboration, which is really central to connected care. And I think connected care became very clear what exactly it is, how it is working, and especially with the last conversation we had in terms of how the consumer is now really empowered as part of connected care. And I think it gives different meaning now to what we mean by connected care. So we'll have to think about that quite well. Collaboration and next steps. I think one of the things which became very clear is that in terms of the forward-looking next steps, where we go from here, the executive circle, which brought leaders from outside of healthcare to contribute to how they see healthcare and what we learned from them, was extremely important. So I think that should continue in future conferences. There's a call to maintain a cross-sector dialogue between the events. So where do we go from here? I mean, this has been a very important contribution. We've learned a lot, we've made collaborations, but now where do we go from here? So at some level, some kind of a dialogue beyond this event, and also sharing insights with the Evercare leadership and the Human Care X programs should continue in some way. The other one is the Evercare Academy. I think we learned a lot in terms of how the academy is actually working. So I think that ongoing capability building, leadership development really needs to continue. Question becomes, how do we then engage the wider public, especially the students who are part of this forum here. The E3 Hub innovation, linking hospitals, startups, investors, obviously that's a major contribution, is something many institutions are doing. And that's one we really should continue. So I think we need to figure out how do we continue that. The whole digital data platforms to enable system-wide learning and collaboration is something that is really important. So that obviously should continue as well. And final closing reflection, Evercare Conference reaffirmed that the global healthcare process requires a shared purpose, innovation balanced with empathy, technology rooted in equity, and leadership grounded in human connection. That's something which Irfan started the conference with, and it makes a lot of sense, that that's really the way we should go. And I'm just summarizing one last sentence, which actually a speaker came up with earlier. What they said was, and I'm paraphrasing, connected care is about people connected by trust, compassion, and a shared mission to heal. Networks, devices, equipment, and technology. And I'll just add in there, networks, devices, equipment, and technology, and AI are enablers. Now, I suppose with the last comment you made that we may be driven by AI is something we need to consider. So anyway, these are sort of final thoughts. Thank you. Irfan.
Okay, as we do the closing, this is the last session. We have a special occasion to celebrate. And I would like Dr. Ayo to please come up because it's his birthday today. And I have a surprise for him. Can we bring the surprise up, please?
Expecting this. If you talk about surprise, this is a real surprise. And then this is the pillar behind everything that I do. Thank you. That's a pillar of strength. I can tell you, I think with this event, this is the best gift that anyone can ever wish for. And I'll tell you, just going through the gift, number one, is that this has been successfully executed. That's the first gift. The second gift is that majority of the people in the audience, they're actually students, medical and nursing, the future of healthcare. That's the second gift. And the third gift is heightened inspiration in my soul, that the transformation journey is kicked off and is on the uprise. That's the third gift. And I would like to thank everyone that's traveled from all over the world to make this happen. I'd like to thank Efan for pushing at the last minute to ensure that this was it's been successful. I'd like to thank all the teams that we put together. I did all the hard work. sleepless nights, and I can assure my wife that I'm going to now devote all the time to her. So relief at last. This is over, and it's now time, all that work-life integration, it's a promise, and we are witnesses. Right here. So I must thank everybody. I think Evercare for me, and she can testify to that, it's been my life. It's a sense of purpose. I just feel that every patient deserves good care, high quality care, 100% safety, and that's what's been driving me. And the inspiration, like I said, after all of this is up there. So we're going to work together to ensure that we give patients the best and also make this quality care accessible and available. It's going to take time, but that's our mission, that's our goal. Thank you very much.
Thank you. Thank you. Thank you. Thank you so much. Thank you for being here. Thank you. Yeah, I think we can have this. Yeah. Okay. I'm going to give my closing speech. This is the final session, and we will be free after this, and it's not going to take long. But we do have another exciting surprise for you. But, you know, before we get there, let me just say that this is what we are witnessing right now is not simply sort of a close of a conference, but it's the continuation of a movement. And what we, you know, that's really where we have all come together, and we've heard, you know, how this conference has been. When we opened this gathering about 3 days ago, we said that emerging markets will no longer wait to be written into the global story of healthcare. And we will write the story ourselves, boldly, collectively, and with purpose. And I'm very, very proud to say that we have done just that. Lagos has been more than a location for us. You know, it's been a teacher, loud, restless, unpredictable, and full of life. We even experienced the Lagos energy the other day firsthand when the skies opened and poured on us, delaying some sessions. But that is Lagos. It doesn't pause long. It shakes off the rain, moves again, faster, louder, and stronger. And that is exactly the spirit we have and that we must carry. Progress that does not wait for perfect weather. So what have we built? Over the last few days, we have built something extraordinary. We have launched the Human Care X, our belief that empathy is not soft, but it's strategic. We have strengthened the Evercare Academy, the platform where learning becomes leadership. We have activated the E3 Hub, where empathy, excellence, and equity meet innovation. We signed the Lagos Pledge, a shared promise to design healthcare not for emerging markets, but from emerging markets. It's amazing to see the many messages and signatures on the wall at the back. Thank you all for doing that. And if you haven't, please, there's still time to do it. We have showed that collaboration is not charity, but it's capability. That excellence is not owned by any geography. And that the Global South will help define the next era of healthcare with confidence and credibility. But perhaps the most powerful thing that I've noticed that has happened this week wasn't really in the program. It was in the conversations during the meals, between sessions, on bus rides, and over coffee. I noticed the teams from all our countries, even after the conference, when we would get together for dinner at the Radisson, by the poolside. Amazing conversations, amazing relationships that are being built across cultures. The teams from Nigeria, Kenya, and Pakistan, 3 countries, 1 platform, eating together, laughing together, debating, learning, and sharing not only work-related challenges, but life stories, hopes, and dreams. It's in those moments that I saw something that data can't measure, trust being built. And that is what makes the Evercare platform so powerful. That we are not just a network of hospitals, but we are a community of people who care about one another and who believe in something bigger than ourselves. And today, as we close, I want to say clearly, the spirit of connection, this platform of purpose, is what we are now inviting the world to join. To be part of a community that believes healthcare can be both world-class and deeply human. None of this could have happened without the extraordinary people who shaped it. So again, Dr. Ayo Shonibari, our conference chair, for your steadiness and clarity that have guided every step. Our co-chair, Dr. Asad Mia, your intellect and humanity have grounded this conference in purpose. To our organizing teams across Nigeria, Kenya, and Pakistan, you worked across time zones, storms, sleepless nights to bring this vision to life. To our partners, our sponsors, your belief fuels our ability to scale this mission. But most importantly, to our incredible staff, nurses, doctors, administrators, volunteers, technicians, your unseen effort is what made this conference flawless. You are the heartbeat of this movement. Let's take a moment to thank and applaud everyone. Before we close, I want to celebrate a few special things. As part of the spirit of inclusion that we always talk about at Evercare and the family that defines this platform, we had 2 participants who were coming here from our hospital in Lahore. And one was part of the leadership training course, and the other had abstracts that were submitted, had team members who were coming in. This is a husband and wife. They both work in the hospital in Lahore. They have a 3-year-old daughter, and they could not travel without her. And they asked me, can we bring her? And I said, yes, you can. And she has been with us throughout this conference, and we will now ask them as a family to please come up. And we are giving her, we'll welcome them on stage, and we present to her a small plaque of the Youngest Participant Award. May she grow up knowing that she was part of something that believed in her future even before she could spell it.
I would like to say a few words. That this is here you see a true picture of empathy that begins at Evercare. So after the leadership training program, it's not what they say, but they do it. So this is the day we are here at the place, at the conference, and whatever was holding us back cannot hold us back. So we are all fired up and ready to go. Thank you very much.
Thank you very much. And next, 2 individuals who carried us through every day of this conference with energy, grace, and professionalism. I can't forget them because they've given these plaques to everyone, so we must give them a plaque each, Saba and Abiodun. Our two MCs who kept us engaged, on time and inspired. Please come forward. Thank you both for representing the very soul of this platform, warmth, structured, and excellent. This week, one message came through every session. Empathy without excellence is sentiment. Excellence without empathy is sterile. From digital health, AI, sustainability, to women in leadership and governance, we saw that progress in emerging markets comes from those who blend intellect with integrity and science with soul. We learned that true leadership is not about hierarchy, it's about humanity. It's about showing up, especially when conditions are tough, and reminding our teams that courage is contagious. So what do we take home? As we leave Lagos, let's carry a few truths with us. That empathy can be engineered into systems, not just spoken about. That excellence must become our daily habit and not our annual aspiration. That equity is not charity, it is the foundation of sustainable health systems. And that connection across borders is our greatest source of strength. If every one of us goes home and makes one small change from one team, one patient, one process, then this week will have been worth it. So the road ahead from here, we move to action. The Human Care X rollout will begin across our hospitals in all 3 regions. The E3 Hub collaborations will link innovators from Lagos to Lahore to Nairobi. The Evercare Academy will scale leadership training for hundreds more. And the EMHX platform will now unite investors, institutions, and innovators under one shared purpose. This is not the end of an event. It is the ignition of decades of transformation. And so let Lagos remember us, not as visitors, but as builders, as people who came from 3 countries, faced the rain, faced the rush, and kept going. Because Lagos doesn't stop, and neither will we. Lagos has rhythm, resilience, and restlessness, and so do we. So with gratitude and conviction and hope, I declare the Evercare Health Conference 2025 officially closed. May we begin in Lagos, echo through every hospital corridor, every classroom, every boardroom, every community we serve. May we lead not just with systems, but with soul. And may we remember the future of healthcare is not waiting, it has already begun. And it began here with us together in Lagos. Thank you.
DJ, this is your time to shine. All right, thank you very much. Let's have Avenue. Avenue, please, can we have Avenue on stage? Oh, it's okay, it's fine. But let's go. Avenue, let's have you on stage. Avenue, can we please get the Kenyan flag? Avenue, can we please have you on stage? Avenue, can we please have you on stage? Everyone from Kenya. Evercare, Kenya, let's have you on stage, please. Your chairman is already here. Can we have the Kenyan flag move forward? Thank you. Avenue, Kenya, let's have you on stage, please. Lahore, please be on standby. Lahore, please be on standby. If you're not a part of Avenue, kindly leave this. Right, hi, hello. Hi, lady, hello. Thank you. Avenue, are you good? Wave your flag, wave your flag, wave your flag. All right, are we good? Thank you. Let's wave as we get up the stage, please. Thank you. Avenue, Lahore, your turn. Lahore, let's come on stage. Can we get the Pakistani flag? Thank you. Evercare Group, every member of Evercare Group, please be on standby. Every member of Evercare Group, please be on standby. Okay, after Evercare Group, we want to have all the students, all of our students who came today. After Evercare Group, we want to recognize you on stage, all of our students, across all the schools. Pakistani flag, please.